We're about to get started. My name is Raymond Fuller. I'm from Boston, Massachusetts. I'm a 9-year prostate cancer survivor, and not only am I a survivor, I'm a warrior. We are going to get started by introducing the founder of PHEN, who is a very close friend of mine. And my Bible tells me that a wise man hears and will increase his learning. And I'm so glad that this gentleman that I am about to introduce listened to that still voice that was within him. When he wrote the book, Knowledge is the Best Defense Against Prostate Cancer, that faith, which is about the size of a mustard seed, has brought us to this place. And I'm hoping that it will carry us far beyond here. I will introduce to some and present to others none other than Tom Farrington.
I hope that's not me. Good morning, everyone. It is so good to see you on the second day of our 12th annual African American Prostate Cancer Disparity Summit. I want to begin by thanking Deacon Griffey. He's a deacon, and he's a member of our PHEN Survivor Network, and a very committed member. He works with us doing volunteer work in Boston and help out with our activities around the country. And not only that, Ray is he's a singer. He can sing, and I said before he came up, Ray, are you going to open with a song? And he said, well, maybe not this morning, but once he gets to lay up the crowd and understand who the crowd is a little better, maybe he'll close with a song. So we may call him up before this is over to have Ray treat us with his musical abilities. This is, as I said, our second day of the summit. We had, I think, and I want to, number one, welcome all of you for being with us today. All of our attendees here and all of our attendees who are joining us online. We are streaming live, so we're reaching people across the country. So welcome. You all look good again today. In fact, I think you dressed up a little bit from yesterday. You look a little bit better than you did yesterday. So we're very, very happy to have you with us. Yesterday, we had two sessions that I thought went relatively well. Our first session was early detection PSA screening, the next chapter. As most of us know in this room, PSA screening has really become a very controversial issue in the medical field, not only in the medical field, but within our communities, because of the task force recommendation against screening that they released in 2012, which turned us on our head 180 degrees, because, as I mentioned yesterday, we were out trying to raise the level of screening within black communities to that within the white communities, and we achieved that goal. And as soon as we achieved that goal, the game changed on us. So we were very pleased yesterday to have with us the chair of the U.S. Preventive Services Task Force, Dr. Kirsten Bibbins-Domingo, and to talk about the plans and what they're doing to update the recommendation, which we expect to happen in 2017, next year. That's a very important activity, very important action, because that will really frame the next chapter of early detection and really frame the next chapter of what we do in the fight against prostate cancer, because it made a big difference what they did in 2012, and I'm sure that 2017 will also make a very, very big difference. So I thought that panel was very good. We got a lot of useful information from Dr. Bibbins-Domingo, from Dr. Ruth Etzioni, from Dr. Wilson, and also from our panelists. So it was a great discussion. That was followed by our discussion on increasing African American participation in clinical trials. And as we know, as some of you may not know, we have a number of new treatments that have been introduced over the past 3 to 4 years, especially for treating advanced disease. And most of those trials had 2 to 5% participation from the African American population, which means that we're really not sure how those treatments work within the population that is most impacted by prostate cancer. So one of our goals at PHEN is to really advocate and try to find ways to increase African American participation. That session was also, I think, very well done, and we had some great presentations by Dr. Mitchell and Dr. Paterno, and a nice panel discussion. So it's something that we're going to build on and move forward with in that effort to increase African American participation in clinical trials. Today, this session is about educating and mobilizing the African American community around prostate cancer issues. That has been a major challenge, and our mission as an organization is to eliminate the disparity, the racial disparity. The racial disparity, for those who may not be familiar with it, is we have an incident rate disparity of 60%. We're diagnosed at a 60% higher rate. The death rate is 2.3 times higher than that for white men, which is the next population. And it is the largest racial disparity for any type of cancer afflicting men or women. And so our goal really is to find ways through all types of activities that I spoke about, what we did yesterday and others, to eliminate that disparity. In order to eliminate that disparity, we must educate and mobilize the community. There's no other way to do that. Because when we talk about PSA testing, when we talk about clinical trials, we're talking one level, but we have to bring that down to the ground troops, and have feet on the ground, and have partners that we can execute initiatives to get people involved. And we have, as an organization, been doing that now since our founding in 2003. And this session, we will talk about some of those activities. And in this session, we will have leaders from other areas talk about what they're doing and how they might be able to join in with our efforts to educate and mobilize the community. We have not done this, what we've done over the past 13 years, without partners. And we've had a lot of participation from churches and other organizations. I know the 100 Black Men joined us a couple of years ago, and we worked together in advocacy efforts. We had the links here, and the links has also helped us with some of our outreach efforts. Our church partners around the country, we couldn't do what we're doing without them. So this session really is to look at some of those initiatives and to assess where we're having success, to assess where we need to enhance our efforts, and talk about ways to make that happen. So that's what we're going to accomplish today with your participation. And we have a great set of people who are going to participate on this program to make that happen. We're going to start this session with some remarks from some people that I'm sure you want to hear from. And it's good to have them here. We're going to actually start out our remarks from Ken Griffey Sr. Now, Ken Griffey Sr., you all might know, I used to watch him on television hit balls out of parks all over the country. And he will not let me forget the World Series in 1975, the Boston Red Sox and the Cincinnati Reds, where we thought we had it. We thought we had that series won. Carlton Fisk, if you all, we remember this in Boston. You all not from Boston may not remember it. But Carlton Fisk in the 6th game of the World Series hit a home run. And Carlton Fisk trotted around the bases with his fist raised as if we'd won the World Series. And we celebrated in Boston because we thought we had won it as well. Well, what happened, that was only the 6th game. There was a 7th game. And Ken won't let me forget what happened in that seventh game of the World Series as the Reds came back and took us down. And, so he's a well-known, great baseball player. In addition to that, Ken is a prostate cancer survivor. And in 2008, Ken joined our Survivor Network. And we invite all prostate cancer survivors and those that want to join our efforts to join our Survivor Network to reach out and help us in our efforts to educate the community where they are, and even nationwide. So Ken and he and I had not met before that time. He went online, joined our Survivor Network, and I saw the name George Ken Griffey Sr. I said, who is that? So I said, maybe that is Ken Griffey. And so I picked up the phone and gave a call to Ken. And Ken made it well known that he wanted to speak out. He wanted to speak out to other men and help in the fight against prostate cancer. So Ken and I got together. I went to Florida and I spent some time with Ken. We did a video together that we released sometime back in 2008, 2009. And Ken talked about his experience with prostate cancer, and let it be known in no uncertain terms that he was ready and willing to speak out and to join the fight against prostate cancer. Well, some number of years later, we're here together again at this summit session, and Ken has joined the effort with BEAR, with a program, Men Who Speak Out, and BEAR is one of our partners and sponsors, and so we are very excited that Ken was able to join us today. So I'm going to bring forth at this point the slugger, the one that took us down in the 1975 World Series, Mr. Ken Griffey Sr. Give him a round of applause.
You did it up. I'd like to thank PHEN for inviting me down here to do a little bit of talking, give you a little history on what I'm doing. I'm working with Bear, my son and I, Junior, as you guys know. He's in the Hall of Fame, just got inducted in July with the most votes ever. But I always tease him that he has all the home runs, I got all the rings. But like I said, I'm working on a program that's called Men Who Speak Up with Bear. And what we're talking about is trying to get men to encourage men to talk about their advanced prostate cancer, about the symptoms. And like I said, the symptoms can tell you if the disease is going to get worse. It's very close to me in terms of I've lost 4 uncles with prostate cancer. My younger brother, Freddie, he just had the surgery last month, prostate cancer. So I'm in the process of running back and forth from Philly to Cincinnati to make sure he's okay. But those are the things I've been working on. Like the most important thing, I run back a little bit, is that my mother was more instrumental in about the prostate cancer because she lost 4 brothers. She raised 5 boys and 1 girl on her own. My dad disappeared on us when I was 2 years old, and I didn't know him got to know him till I was 15 years old. So, but she took it on her own to make sure that when we got older, to take care of your health. And that was one of the biggest things that she was very adamant about. Well, so by the time I got 34, 35, the prostate thing was coming into being, and I had to take the test and everything. And being an athlete, you got to understand that athletes believe that they're invincible a lot of times. Nothing can happen to them, I mean, I went through a lot of change. I was just telling the gentleman today, I was telling him I played 6 weeks on a broken knee, and a broken knee is we had MDs for doctors as team physicians. You got to understand, we didn't have orthopedic surgeons. So the only thing they can do is prescribe an aspirin or ice, to put on it. That was about it. But I played 6 weeks with a broken knee, didn't find out. They started doing the arthroscopies and all that. That was the first time I started doing that. And that's how they found out I broken knee. But getting back to what I was actually talking about was the prostate cancer, with being a partner with Bear. and going over all the things and men who speak up, and that's just to get men to talk about it. I've had a lot of friends that had prostate cancer. I played golf with them. Until I was diagnosed, they would never talk about it. And I mean, 2 or 3 years, they had already had the surgery and everything, but they never talked about it. So I'm here to try to get men to speak up, talk about it, talk to their doctors, whoever they can talk to. You know, in the African American community is the toughest situation because I have an older brother that won't go to the doctor, you know, and he's going through a lot of changes right now, but he's too bullheaded to go. So my younger brother, who just had surgery, called me the other day and he said, would you come to Cincy and try to take Bill to the hospital or to a doctor? And so my job is running back and forth. I'm retired now from baseball after we beat up Boston. Yeah, I really didn't know you liked Boston. I thought you would like the Yankees or something. Yeah. But like I said, I'm running back and forth to Cincinnati to make sure everyone in Cincinnati is okay. So, but I'm very happy to be here. I'm glad Tom asked me to come down and talk. You know, like I said, we lost contact since 2008. You know, I wanted to become a scout, and I didn't hear from you, or I forgot where you was at. You know, and I ran into him in, was it Newton? Yeah, up in Massachusetts, and that was 8 years. So, and he asked me, he said, what are you doing? He said, you want to come to D.C.? I said, hey, I'm coming wherever they have a prostate cancer convention somewhere. I'm going to come and hopefully help out and talk to people about that. But I just want to say that we have a website, and it's menwhospeakup.com. And most important, it has a lot of information on advanced prostate cancer and all about symptoms and everything else. So if you want to look that up, that'll be fine. But this is what I'm doing. I'm going around the country and talking to people about advanced prostate cancer and our campaign, Men Who Speak Up. And it's very important to me. So I just want to thank you, and you know, you guys have a good day, and I'm going to have a good day. I know that.
Thank you.
You want to sit up here? Or
No.
is they gonna ask you? Okay.
Thank you, Ken. No, I'm not a Yankee fan, Ken. You know, I'm a Red Sox fan. There's a world of difference between a Yankee and a Red Sox. Yeah, I'm positive. I belong to a fraternity, and it is it's the oldest black Greek letter fraternity in the United States. And we have 150 chapters around the country. The fraternity is the Sigma Pi Phi fraternity, better known as the Boule. I'm a proud member. I've been a member for many, many years. And within the Boule chapter, we have a Beta Beta Boule in Boston. And when I started PHEN some years ago, after I wrote my book, Beta Beta was a strong advocate for the work that PHEN is doing. They got involved with things that we were doing in Boston. I made sure that they all bought 3 copies of my book, give it to mom and daddy and brother, whoever could read within the family. And so where we are now is that we have a leader, Mr. Wesley Coleman, who's a good friend. And we've known each other for a good number of years. Sigma Pi Phi is looking to kind of bring prostate cancer within the chapters across the country, make that a priority in terms of their social action commitment. And Mr. Coleman spoke about that when he was inducted as a president just this year. After that, I said, Wes, we need to bring you in and get you involved with our summit. Have everybody hear you say that again loud, and we are on the internet, so people tune in all across the country so that we can move forward. Because as I mentioned before, we can't do what we do without good, strong partners. And the 100 Black Men, you know, when we had to work to have the U.S. Preventive Services Task Force changed their research plan for the work that they're doing now to gather the scientific evidence for the recommendations going to come out in 2017. The 100 Black men joined with us for a strong advocacy campaign. And their leaders, chapters all across the country, joined PHEN in writing letters and supporting that change. And that change did happen. And without their support and without the support of a number of our church partners, I don't think we could be where we are today looking for some liberation in 2017. So we really are looking to have Sigma Pi Phi join us as an active partner and other organizations. So at this point, I'm going to introduce Mr. Wesley Coleman to come forward and talk to you about Sigma Pi Phi fraternity. He is, Wes is a retired executive with a lot of top-level experience and an organization. Walt Disney, he was executive vice president. At Nike, he was executive vice president. He is the chair of the Hampton University Board of Trustees. So with Wesley, we have an esteemed leader. And I know that Wesley can make anything happen. So on that note, I'm going to invite Wesley Coleman to come forward.
Good morning. You know, I remember that game in 19...
Oh, no.
Yeah. But the thing, I remember two things about it. I was living on the East Coast, and it came on at a normal time, but it went very, very late. And when Fisk hit the home run, I got so excited. After the game was over, I couldn't go to sleep. And I stayed up late, and that was in my 35-year corporate career. That next morning was the only time I overslept and was late for work. So I want to thank you for that. All right. Well, thank you for inviting me to give you an opportunity to talk a little bit about this very critical health issue that, you know, disproportionately affects our African American men. Now, Sigma Pi Phi fraternity, we call it the Boule, was founded in 1904, and it's the oldest African American fraternity. And today we have over 5,000 members across the U.S. and internationally. So I'm honored to serve as what we call the Grand Sire Archon, which is the same as the national president. And with me today is our chairman of our Social Action Committee, Dr. Gerlando Jackson. Stand up a minute there. Now, you're going to hear from him a little later because he's going to be on the panel. And he is a professor at the University of Wisconsin-Madison. And he will talk a little bit more in detail about our programs. Now, we all know the statistics regarding prostate cancer and how it affects African American males disproportionately, and that while the disease typically shows up in males over age 50, we African Americans seem to develop it at an earlier age than our white male counterparts. And we also have a higher malignancy rate. But we're also very aware of our dislike for the digital rectal exams, which are considered the simplest and the most cost-effective way for screening. Now, knowing all of this, it's also clear that early detection is the answer to the cure, and the annual rectal exam by your physician is the answer to early detection. So, within the Boule, we have an extensive social action program. It focuses on ways that we can support and provide initiatives that benefit our Black families, youth, and communities. And a key emphasis for many years has been our effort to really cultivate and celebrate the academic excellence of Black students, especially Black males. And we accomplish that through many things, including mentoring, scholarships, and encouraging ongoing networking opportunities. However, we realize that if we, as an organization, are going to help our youth, we first of all have to be around and in good health. So thus, we've taken on a healthy lifestyle initiative, and it's going to focus on a few things: exercise, proper diet, and good health. So how many of you exercised this morning? All right, good. Yeah. Tom and I Tom and I are in an organization that we get together and have a lot of fun and typically have some late night gatherings. And, but I make it a point that I always get up the next morning. I don't care how late I stay up and try to exercise. So this morning I had a nice walk around the White House, and I wanted to see everybody out there exercising. Now, so we're focusing on exercise, proper diet, and good health. Now, the demographics of the Boule, it's all male, and our average age is slightly over 50. So that would predict a high incidence of prostate cancer for our members. So we feel it's an obligation to better educate both ourselves and our communities on the devastating results of untreated prostate cancer. So in a number of cities around the country, we have conducted free prostate cancer screenings while utilizing physicians who are members of our Boule to perform the tests. We fortunately have members who cover really all occupations and quite a few physicians, so they are willing to give their time freely to help in this. So our goal is to greatly increase the number of communities where these types of screenings will be held. And in all cases, we will offer these screenings at no cost to the individual, and we'll also undertake an educational effort to remove the stigma of the rectal exam. So later on, you're going to hear from Dr. Jackson to talk about some more specifics of what we're doing. But one other thing I'll mention, and Tom mentioned that I'm chairman of the board of Hampton University, which is where I attended school. And in case you didn't know, Hampton University has a prostate cancer treatment center, a proton beam cancer treatment center. And it's unusual that a mid-sized liberal arts school without a medical college would have a treatment center like that. But a few years ago, our president and the board of trustees decided that this issue of prostate cancer was so important and was having such a devastating effect on our communities that we wanted to do something. So we have put up this very nice facility, and we have treatments. We're treating about 50 patients a day. We found that there's a lot of controversy about what's the best treatment, but certainly the proton beam is probably less intrusive and has had very good results. So I'm proud to be associated with two organizations that are really making an effort to have an impact on our communities. And we also know that in many cases, individuals cannot afford the treatment or don't have insurance. So we at the Hampton University Proton Beam Center have an opportunity to provide treatment free for those who cannot afford it or who don't have insurance, and we do that through various fundraising efforts. So with that, I think I'll end, and I look forward to you asking my colleague, Dr. Jackson, more questions as he participates in the panel. All right.
Thank you, Wes. Thank you, Wes. Wes, I'm glad when you watched that 1975 World Series that you were on the Boston side, so. I didn't say that. Well. I'm really a Dodger fan. Oh, very good. I was a Dodger fan also throughout my young years before going to Boston. So again, we thank Wes for those remarks, and we really look forward to forming a good working relationship with the Boule chapters across the country. The next person that I want to introduce and make remarks is a person that is Dr. Mitchell, and Dr. Mitchell is the immediate past chair of the National Medical Association. And when I talk about organizations that we formed a relationship to work with, the National Medical Association is one of those organizations, and one of the foremost organizations, because we have within the Medical Association black doctors across this country. And we need their expertise. We need their support. And so we are very, very happy that they are with us. And that's a partnership that we value. It's a partnership that we're going to grow with. Dr. Mitchell invited PHEN to participate in a number of the NMA activities this past year, and she was with us last year in this summit, and she spoke yesterday on increasing clinical trials participation, and she's with us today, and she's committed to be with us next year. That's what she said as we left the meeting. So we value greatly the partnership and relationship that we have with the NMA, and we look forward to growing that. And so with that, I would like to introduce Dr. Edith Mitchell.
Good morning. How's everybody today? We're up bright and early. So it's a privilege for me to be with PHEN again, and Mr. Farrington. We've had some great meetings, and I am very appreciative of the collaboration between PHEN and the National Medical Association. Mr. Farrington and I have made sure that there are multiple opportunities for us to meet. And there are other things. Mr. Coleman, you will know I'm at Thomas Jefferson University. That's where the Boulé was formed. And in fact, the first African-American graduate of Thomas Jefferson University was one of the founders of Boulé. So we're actually very happy to work with you. There are just a few notes that I really want the entire audience to know, and that is we all must work together. Medicine, legislation, communities, individuals, everybody, because if we combine our efforts together, our forward momentum is enhanced tremendously. So it's really everybody working together. Now, what are some of the things? For medicine, the number of Black male physicians in this country has decreased. In a large report in 1968, during the President Johnson's administration, and remember he had the Great Society, and lots of things happened as a result of that. Medicare was one, and African Americans have had the greatest benefit from Medicare than any other group, racial or ethnic individuals. Another was education, where the educational opportunities for African Americans increased significantly. And in a large report in 1968, there were 532 Black men entering medical school. Fast forward to another report in 2012, only 512 Black men entering medical school. And what that means is that the number of physicians in our communities who can speak for us, who can understand the culture in the African American community, who can understand all of the increases in incidence rates, mortality rates from various diseases, including prostate cancer. So understanding and having individuals who look like us in our communities, who understand us, who can speak for us, is really very important. So one of the areas that Boulé is working with us, and we had a large meeting at Thomas Jefferson just a couple of months ago, and this initiated a national program of increasing African American males in medical school. So it's starting really at the elementary school age, encouraging students to enter the sciences, to understand the sciences, and to choose those courses, rather than saying, oh, algebra is too hard, don't take it. So working in our communities to increase the students who are interested in medicine. The legislation to give more scholarships and financial assistance to individuals who are interested in medicine and the sciences. So that's one area where we're working with. Another is increasing the number of African American men who have prostate cancer on clinical trials. And we all know there are multiple reasons why members of our community don't participate in clinical trials. I have the privilege of being a part of Vice President Biden's Blue Ribbon panel for the Moonshot Initiative. Moonshot, of course, was discussed by President Obama in his State of the Union address January 12th of this year, when he described the moonshot and what he wanted cancer researchers to do to improve and increase the cancer prevention, detection, treatment, and all of those activities. And his challenge to us was to finish 10 years, a decade of work, in 5. And he says, I'm putting Joe in charge of it. So it was announced a few weeks after that that Vice President Biden had selected 28 individuals in this country to assist him in bringing forth this. And I am privileged and absolutely honored to be one of the 28 individuals. So participation in clinical trials is really something that we want to get out to the public. We will do genomic testing on tumors. We already know from testing a few individuals that prostate cancer in African Americans tend to have different genes and a genomic profile from prostate cancer in Caucasians. We also know that there is a higher incidence in this genomic profile of those characteristics of tumors that make them more aggressive, grow faster or proliferate faster, and therefore metastasize to other organs quicker, and thereby contribute to the death of the patient. So we are very, very interested in that. And Mr. Griffey, you will be interested to know that we have a category that we call inherited prostate cancer, where 3 or more family members from more than one generation have prostate cancer. So we're working with that to do genomic profiling on individuals. But the important thing that I want you to take home is that it's not just prostate cancer. Certainly, if there's a family history of prostate cancer, there is a higher risk of individuals developing prostate cancer. But also, if there are family members with breast cancer, whether they're men or women, and yes, men do get breast cancer, as well as if there are family members with colorectal cancer. So not only do we have to know our family history, but know that these other cancers, if they occur in family members, puts the males in a higher risk category for developing prostate cancer. So thereby, it's understanding this, participating in the clinical trials. And with the Moonshot panel, we have recommended to the Vice President that we need to make sure that these new cancer therapies and trials for prevention are in the communities of higher risk, and therefore working with the communities, working with the Boulay, working with PHEN and the National Medical Association, we intend to carry one voice that, yes, we need more research on not only prostate cancer in African Americans, but other cancers. And that comes down to clinical trials. For many clinical trials, many individuals say, well, I don't want to do it, I don't want to talk about it. Also, the majority of physicians, basically Caucasian physicians, but others who are not African American, assume that African Americans don't want to participate in clinical trials. So we, again, need that one voice. Yes, we do want to participate in clinical trials, but the treating physicians must be culturally sensitive to our needs and the needs of individuals in our community. So I'd like to finish with saying we are working with the Vice President to get this information out there. It will be implemented by the National Cancer Institute. And the National Cancer Institute, how does it operate? Through funding. And how does it get that funding? It's through the legislation and our legislators. So therefore, we've got to form our warrior hat. And you know, I can wear a warrior hat, right? I have the privilege of 34 years, 6 months, and I think 23 days in the Air Force, and was very privileged to have many positions there that allowed me to be able to speak for a lot of people. So I am so pleased to be here today. I am pleased to represent the National Medical Association in this effort, and we'll all work together. And I look forward to more individuals. Next year, the National Medical Association will meet in our great city of brotherly love. And we say yes, sisterly affection. So I hope to see everybody with PHEN. And of course, PHEN is a partner with us in our National Medical Association effort. So I will speak for next year.
We'll be there.
And we'd love to have all of you there as a part of that. So thank you so much for allowing me the opportunity to speak.
Thank you. I want to thank Dr. Mitchell again for her commitment, for her time. She's been with us the last 2 years. And for those, Dr. Mitchell said that she's held a few positions within the military, and she's a retired general. So that's a pretty big position. So in addition to being one of our medical leaders and one of the world-renowned leaders in the medical field, she is a general as well. So thank you again for being with us today. Now, this is our 12th annual African American Prostate Cancer Disparity Summit. And I kind of told you yesterday, for those of you who attended, how we got started with my senator, who's now the Secretary of State, John Kerry. When he was diagnosed with prostate cancer, he and I was chatting. I gave him a copy of my book, and he read it and sent me a note. Said, Tom, I didn't know that black men suffered from prostate cancer this way, this much. Anything I can do to help, let me know. When he got to his office the next day, he had a letter from me. Said, Senator Kerry, I want to put together the summit in D.C. To bring together our political leaders, our medical leaders, the pharmaceuticals, the prostate cancer survivors, and community leaders. And he said, okay, we're going to do that. And he reached out to Congressman Gregory Meeks from New York, a member of the Congressional Black Caucus. And so in 2005, we held our first summit. And we held that first summit in the Raven House office building. Both Senator Kerry and Congressman Meeks were there to help us kick that off. And since that time, we've held the summit every year. And beginning a few years ago, I think beginning 2 or 3 years following that, we made one day of the session part of the Congressional Black Caucus annual legislative conference, which is where we are today. And you know, we don't have a member of the caucus in Massachusetts. So my leader in the Congressional Black Caucus is Congressman Gregory Meeks. I adopted him. Therefore, he was kind of forced to accept me. And so after, as I said, 12 years, we're still together, and he has provided just outstanding leadership for us in the House of Representatives and in Washington altogether. You know, we met yesterday in the Capitol. I cannot call up the U.S. Capitol and say, I want a room, I want to rent a room, I just want you to put me up. It was Congressman Meeks who reached out as a congressman and said, we want this room reserved for PHEN. And that's how that happened. So we thank him for that. In addition, he's made this available today is one of his brain trust sessions. So he's actually our official host for this event today. And Congressman Meeks, and I saw my good friend Elliot Holt walk in, and I know Wesley Coleman. We are all members of an organization called the Guardsmen. And so we get together a few times a year just to let our hair down and do unofficial type things. And so I just want to say that Congressman Gregory Meeks is our leader in the Congressional Black Caucus and in Congress for this fight against prostate cancer within the black community. And we really benefit from his leadership. We appreciate greatly his leadership. And with that, I want to bring him forward now. Give him a round of applause. And by the way, I just say this. I did see him running with his wife, Simone, this morning, getting his exercise in, Wes. And I would have been running too, but my wife didn't take me out like so.
Good morning. Indeed, it's good to be here for the 12th annual session with PHEN and with my good friend Tom Farrington, who he's had the vision to make sure that we continue moving forward and that we will not stop until we save as many lives and are able to eradicate this disease and make sure that information is disseminated to all about, because it is a disease that can be caught and found easily and cured if we just get examinations. Let me first do, I think, the appropriate thing for me to do as your host is to welcome you to the 46th 46th Annual Legislative Conference of the Congressional Black Caucus. It is a caucus where we try to come together to give a message that can benefit all of America. And I can't think of a more important time to be here to discuss various issues than today. But we call these brain trusts. And when I talk about the PHEN brain trust, that's exactly what it is. Different than some other brain trusts we have, because then we're trying to attract people in who may not know or may not be the experts in a particular field. This is a brain trust, because those of you in this room are the ones that we have to depend upon to go out into the fields and to make sure that the word is spread so that we can make sure that everybody understands and gets the information that's necessary so that it can either, as Dr. Mitchell has talked about, make sure that we have more folks of color to become in the medical profession so that they then are more sensitive to the communities of color. You go out to the communities of color as the experts dealing with the hospitals and the other and doctors and our other organizations to make sure that word gets out. So you really are the brain trust when it comes to prostate cancer that we've learned to depend upon to make a difference throughout America. So I was thinking when I was coming here, because one of the things, of course, just this past year, while we've got to continue to push, I lost a dear friend to prostate cancer simply because he didn't go get a regular checkup. Would still be here today. And then when he found out, it was too late. It's still that, particularly with African-American males, I have found that we still got to fight to make sure that their health is important, because without health care, you have nothing. That's why you saw my wife and I walking this morning, because I know that you're not here forever. But we want to be healthy when you're here, and we want to make sure we preserve and keep families together. So the message really that I have for you today is that I know that PHEN is reaching out now, and there's going to be programs across America in various churches. The Boule is doing what it needs to do to help doctors, but also educate its men. We were talking the other day with our fraternities and sororities, because the women are clearly involved, because Sometimes us men, that's who we do listen to. That's who will get us to the doctor. So it's that connection that's important in networking. But what I wanted to add to this is sometimes we got to make sure that we start at the ground level, because Dr. Mitchell also said something that I wanted to talk about, because sometimes you need the funding that's necessary. And the funding doesn't start, sometimes I don't believe in the trickle down. It's from the bottom up. So we've got to start concentrating also to make sure that our cities and local municipalities are participating in this. Because oftentimes the way it works, we may get healthcare federal dollars, but we don't get to earmark where those healthcare federal dollars go. We just send them to a state or local municipality. And then within that state or local municipality, they decide where they go. So we've got to begin, and I'm talking to my local city council people and my state legislators, so we've got to begin to work them so that they are putting specific budgets aside within their healthcare budgets that can be utilized to make sure that we're funding programs and education to deal with prostate cancer. It is tremendous. It is something that has to be connected, because it is that connectivity that will make a difference and cause the message to spread. Now, what I have learned over the 12 years is, and I see the individuals that you're going to have on the panel, they are innovative. The techniques and technologies and things that have gone on from 12 years ago to today have improved substantially. I've heard and listened, and Tom has made sure that we've gotten copies of the very latest in research and equipment, and then what we need for the future. And that's why we've got to make sure that there's a 12th and a 13th and a 14th and a 15th presence here at the LCL, and make sure that you stay together and you're as strong to continue this message. Because if there's one thing that we know, that this does not go away overnight, and it does not go away if we're silent. So we will continue to fight on the Congressional Black Caucus's side to make sure that that is part of our core mission when we talk about health care, which is why it was tremendously important. I end with this, because what happens is, and why, if you don't have health care, you can't access it. And that's why the Affordable Care Act that President Obama put forward when he first got elected in 2008, and Lord knows I'm going to miss him next year, was tremendously important, because over 20 million Americans who did not have access to health care. And when you look at further disparity between the haves and the have-nots who suffers from this disease, it's great. So we've got to make sure individuals, health care should not be just a privilege for a few. It should be a right for everybody. And we're looking to move that forward. And so I ask you to continue what you do all the time, to continue to fight when you leave this place, because that continuity is so critically important. So critically important when we talk about health care. And you are indeed our messengers. You are indeed our brain. So therefore, it is reason why we call this a brain trust, because we trust you to do what is necessary to get done. Thank you, and I hope you have a great conference and enjoy.
Thank you, Congressman Meeks. Thank you. Congressman Meeks talked about the resources, the financial resources at the local level. And I would say that we worked in Massachusetts just this year to get an earmark to reach out throughout Massachusetts in the community with our programs. And, we have not used resources from the government. PHEN literally has supported our activities from our general sponsors. Let's give our sponsors a hand. And you can see who they are on the back of your program. But let's give our sponsors a great round of applause. But we did put this in place in Massachusetts. We had to walk the halls to get it through Congress, get it signed by the governor, and that's a model that we plan to use around the country. We're going to try to increase the resources. We need additional resources in this fight against prostate cancer in our community. So we're going to use that model to enhance and accelerate the progress that we're making. So, so everybody's still doing good this morning? Everybody's fine? Good, thank you. Now, the next part of our program will include a presentation by Dr. Hall, and then we'll have a panel discussion. And I'm going to introduce our Director of Outreach, Mr. Mark Kennedy, to come forth and conduct this next session. First, I'd like to say is that many people ask me about Mark, how long, I hear people asking about how long have you been with working with PHEN? And Mark joined us a couple of years ago on our payroll. But Mark has been working with us since we were organized in 2013, because he was on the payroll of the Dana-Farber Cancer Institute, and he was running their prostate cancer outreach program. So really, we've been together pretty much the whole time the PHEN has been in operation, and he knows intimately what we do in our programs, and we're pleased to have him with us. So let me introduce you to our Director of Outreach, Mr. Mark Kennedy.
Thank you, Tom. Hello, everyone. All righty. Hope everyone's well, and I hope you're ready for what I anticipate will be another exciting session. I don't know how many of you were at yesterday's sessions, but we had a wonderful, wonderful day yesterday, and this will culminate what I think, again, will be one of our best summits, so welcome aboard. Let me recap what Tom said at the beginning of today about what we're going to be doing today. Session 3, as Tom mentioned earlier, is about meeting the challenges of educating and mobilizing communities of color around prostate cancer issues, okay? We've made reference to a very distinguished group of people that are going to help us have that discussion, but we really want to accomplish 3 things with this session. The first thing we're going to do is we're going to identify and describe some initiatives that are targeted toward the African American community. The next thing we're going to do is try to assess the impact that those initiatives have had on not only changing the culture, but actually mobilizing and generating some activity around what we should be doing as a community. And then last but not least, of course, we want to open this up to what I think will be a more innovative side of the discussion in terms of identifying potential solutions and describing what we should be doing going forward. So we're going to start off with a presentation by Dr. Lannis Hall, as we've said before. Once Dr. Hall is done, I'm going to ask her to join the panel, and we've got, again, as people have already referenced, a number of distinguished people that will talk about initiatives that are involving the faith-based community, public health, health administration, and a variety of different things to help us sort of round out this discussion. But at the very first, what I'm going to do is start by describing some of the PHEN initiatives that we're involved with before I turn the floor over to Dr. Hall. So whoever is changing slides, or am I doing that? Okay. Excellent. Outstanding. All right. Excellent. Thank you, Tamika. So we talk a lot about these numbers, so I'm not going to spend a lot of time here. Everybody, I think, understands from a quantitative point of view the disproportionate burden of prostate cancer in the African American community. So I think we can pretty much understand and get to some of the things that we really need to talk about in terms of PHEN initiatives. And you've heard Mr. Farrington talk about this before. PHEN's position is that knowledge is the best defense against prostate cancer, and of course we all know that to be true. And given that the African American community bears the largest burden, it really is important for Black America not only to be the most knowledgeable, but I want to emphasize the most engaged. And the engagement is really what we're going to be talking about in this session this morning. So here are a number of initiatives that PHEN is involved with now. The Survivor Network, of course, is the cornerstone of what we do, and that's really how we launched PHEN in 2003. The other thing that Tom referenced is in 2003, we started a partnership with the Dana-Farber Cancer Institute, and of course I was working there at the time, and that monthly support group has been a mainstay of the direct service that PHEN provides to men that join us. PHEN Television started in 2007, and those of you who have been to our website know that there is a wealth and myriad of a variety of information that has to do with prostate cancer that is archived there for your reference. So anything that you want to know about prostate cancer, you pretty much can find on the PHEN website. We also have an annual Father's Day rally that really describes our very long-term relationship with the faith-based community, so that every year on Father's Day, we have a number of churches around the country that acknowledge the members of their congregation that have been impacted by prostate cancer. And I'll talk about that more in a second. The monthly webcast piece was a way for us to literally take our model and begin to sort of disseminate that across the country. So the educational component of the model is now available to people in remote locations through the webcast. And then in 2013, we started doing these events in discrete cities. I think in 2016, we had 17 such events in 17 major cities across the country, where we brought church partners together and provided a one-day educational symposium. And again, I'll talk about that just a little bit more in a second. Now, one of the things that I do, and it's one of my major charges in directing outreach for PHEN across the country, is to take the model of the monthly support group and create activity hubs in discrete cities across the country. And I'm proud to say that we actually started one this spring in Washington, D.C., and I see my partner Clinton Burnside out there. He actually moderates the one at the Howard University Cancer Center. So let's talk about these things sort of each on their own merit. So the Survivor Network, again, this is the foundation of the PHEN education and outreach programs efforts, started when PHEN originated in 2003. We have over 200 members in the network nationwide, and basically we lead and support local community educational efforts through the work that this volunteer corps does for us. I also mentioned again the Dana-Farber Cancer Institute, and I'd like to invite you to think about the monthly meetings as a binary model, if you will. So there are two components to it. One of them is a service component, the other is an outreach component. Now from the service side, we invite newly diagnosed men and survivors, caregivers and their families to really provide them with education, patient navigation, medical advice through our medical advisor, and a number of different things to help them navigate through that journey. And from an outreach perspective, we have community outreach activities that include, healthcare events, educational events like the symposia, and things of that nature. So again, it's just as much bringing men into the fold to give them what they need, as much as it is engaging our surrounding community to make sure that we are getting the word out about issues that relate to prostate cancer. We also train members of the Survivor Network to continue to be effective at their work. And again, this monthly group that we're talking about, again, we want to replicate this model and create hubs of activity in key cities around the country, and that's what the PACO was set up to do. So again, I'm working with Howard University here. We have a number of different initiatives in Boston that expand beyond the Dana-Farber piece so that we can encompass the entire state of Massachusetts. We have one in Charlotte, North Carolina. We work with Michael Shaw out in Oakland, and a number of these other initiatives. So we're looking to identify a number of these so that we, again, can have local activity hubs in key areas around the country to make sure that we're getting the word out in the proper fashion. Now, the online piece, again, we have PHEN Television, as I talked about before, the monthly webcast, which features, again, educational presentations that are webcasted to remote locations. That information is then archived on the PHEN website, so at any point, you can go to the PHEN website and take advantage of that content. The Father's Day Rally and Symposia I talked about. So we have a lot of different things that are available to you online if you go to the PHEN website. And oh, by the way, that's www.prostatehealthed.org. Okay? Again, one of the mainstays in terms of how we do the work that we do is our partnerships with the faith-based community. So we've been using those partnerships and taking advantage of those partnerships to conduct outreach and educational activities since 2009. We've got over 400 church partners nationwide, and we find that because of those embedded men's health congregations, there's a very large thirst in the faith-based community for prostate cancer information, and there's a lot of good energy and resources around helping us get the word out to our men. And as I mentioned, the Father's Day Rally is interesting. These educational symposia that I've been talking about sort of happen on a staggered basis. So we start around end of April, early May, and every Saturday there's a symposium in a different city. And all of those culminate on Father's Day when, again, all of our church partners around the country acknowledge their congregants that have been impacted in any way, shape, or form by prostate cancer. It's really a beautiful sort of crescendo of activity from April, up until Father's Day that really engages a lot of people around the country. It's really nice. So again, we do these annual educational symposia. This year was the 4th annual. We did 17 of them, as I mentioned, across 12 different states. And we educate about risk, early detection, treatment, survivorship. And these things are led by volunteer medical faculty. They're organized by church volunteers. And again, through the pesos and the other work that we do, we have a large volunteer base that really helps us not only pull this together, but to do the outreach in the communities to make sure that people are aware of them. So PHEN, I think, has a really comprehensive set of activities that really inform the efforts around mobilizing and educating communities of color about issues that relate to prostate cancer. What I'd like to do now is introduce our presenter, Dr. Lannis Hall, and she's going to be talking about some of the work that she's doing in the St. Louis area. Dr. Lannis Hall is the Director of Radiation Oncology at the Siteman Cancer Center at Barnes Jewish St. Peter's Hospital, and she's the Assistant Professor of Clinical Radiation Oncology at Washington University School of Medicine. Since 2006, Dr. Hall has led the Clinical Trials Outreach Corps and developed the clinical trials video and brochures used throughout the Siteman Cancer Center at Washington University School of Medicine, Barnes Jewish Hospital, and featured on the Clinical Trials webpage. She's a member of the Disparities Elimination Advisory Committee for Washington University and has served in that capacity since 2008. And she's a member of the Siteman Cancer Center's Senior Leadership Clinical Research Subcommittee, and she has served in that capacity since 2010. She helped develop the Health Connections Radio Partnership with Gospel 1600 and with 100.3 to the St. Louis community. She's also co-founder of the Prostate Cancer Coalition, which is a group of physicians, prostate cancer survivors, and community organizations dedicated to raising awareness about prostate cancer in high-risk men. She's a featured columnist for the St. Louis American, and there was a reference made by one of our panelists yesterday to an op-ed that she wrote for the New York Times called Prostate Cancer is Not Colorblind. For those of you that have not read it, I would strongly encourage you to do so. It's a very, very good article. Dr. Hall, please.
Good morning. I want to thank Mr. Farrington and Mr. Kennedy for the invitation to present our educational campaign in St. Louis. I would say after 24 hours, I consider myself a PHEN family member. So I am now going to call Mr. Farrington Tom and Mr. Kennedy Mark. I want to give you a little history regarding how this educational campaign came about. For the last 10 years, as Mark stated, I run the Clinical Trials Outreach Corps at Washington University. And that charge is to make sure that there is adequate enrollment of minorities on clinical trials. And that is because there's a mandate, Public Law 10343, that in 1993 stated that there must be inclusion of women and minorities on clinical trials. And particularly phase 3 clinical trials must have adequate minorities to provide a subpopulation analysis to make sure that a study, if we're going to use the evidence from the study, is applicable to all populations. So we were shocked when in 2012 the U.S. Preventive Services Task Force used a study, PLCL study, that did not have adequate representation of African American men on that clinical trial. They used that data to no longer recommend screening for any man, regardless of risk group. And African American men had the most to lose from the change in that screening guideline, but yet there was no evidence because that phase 3 study had inadequate representation. So here I've worked for 10 years making sure that we had appropriate minority representation, and to find a policy body that did that was egregious. So that's the backdrop to this educational campaign. Do we have an answer? Okay. I'm going to just briefly describe the St. Louis metropolitan area. There's 2.7 million residents in the city and the county. That black line demarcates the city-county border. 310,000 in the city of St. Louis. And St. Louis has African-American population of about 50%. Just like many urban centers, St. Louis is segregated. The majority of African-American men live in the north of St. Louis and in the north of St. Louis County. I think with the lighting, you probably cannot see the hash marks in certain areas of St. Louis. They're predominantly to the north, but those are high areas of need. And what that means by high areas of need is that there are exceptionally poor health outcomes in this area, and in addition, low access to medical care. We wanted to know in the St. Louis region where prostate cancer mortality was the highest. And in the areas in red, this depicts a mortality rate that's over double the rest of the state. And those are many areas in North St. Louis and in North St. Louis County, Wellston, Normandy, and Ferguson. In St. Louis, we have 2 community advocacy groups that have worked for years, tirelessly doing work in the community. One is the Empowerment Network, founded by prostate cancer survivors. They have a radio show. They provide post-surgery kits to men after prostatectomies. They offer free screenings in partnership with other health service industry. Now, the 100 Black Men of St. Louis, they have been outstanding in annually providing and sponsoring a prostate cancer walk where they also offer screenings and education to their members and to the community. And I've been happy to work with both of these groups and particularly speak at seminars with the 100 Black Men for the last 9 years. There are exceptional barriers to providing prostate cancer education and screening, unlike we see in any other disease site. And let me just go through a few. The first are what I call stigma or issues of manhood. In the 1970s and 1980s, over 50% of African American men presented with metastatic disease. So that's disease that's outside the confines of the prostate and has spread to liver, lung, and bone. That is in the 70s and the 80s. The treatment in the 70s and the 80s, as it is now, is to lower the testosterone level, which is a main driver for prostate cancer growth. In the 70s and the 80s, the way that we did that is with castration. That is not a surgical procedure a physician wants to do, nor does the patient want to receive. But it was what was commonly done because 50% of men, African American men, presented with metastatic disease in the 70s and the 80s. So what does that mean? There's a whole generation of men who were not talking about prostate cancer with their family members. They did not come home from the hospital to talk about what happened that day. So there's a whole generation of men who have a code of silence. And those are fathers who didn't talk about prostate cancer to their sons or their brothers. And I see it all the time. I practiced for 20 years. Can you tell me your family history? My father had something to do with his prostate. That's all I know. If you go to the mother will tell you a little more detail. But they did not discuss this. So this is the history that we have to overcome now when we're trying to get men to talk about going to get screened and having physical exams. There is a high rate of indolent lesions that may not be clinically relevant in prostate cancer. That is difficult for even physicians to understand. What I mean by that is there's a wide biologic variability in prostate cancer. There are some that can sit in the gland for years and never spread. We call those clinically insignificant lesions, where they will not affect a man's lifetime. But then there are others that are destined to grow and spread and metastasize and cause death. That's called a wide biologic variability. And that is why you hear, my doctor said that I could be watched carefully, active surveillance. Well, we know a lot about who should be directed towards active surveillance and who shouldn't, but imagine trying to have that conversation while you describe the importance of prostate cancer screening, and they hear that, well, if you have it, maybe we don't even have to treat it. We don't have that problem in lung cancer. You've never heard someone say, I've been diagnosed with lung cancer and we're going to watch it, or colon cancer, or breast. This is an exceptional barrier to delivering healthcare information. A lack of robust level 1 evidence. And what I can say, since I'm in clinical trials, is if you have 6 randomized national and international trials like we have in breast, in the comparison of mastectomy and breast conservation, and all of them said the same thing, they're equivalent, it's easy for the doctor to read 6 studies and say, this is the standard of care. You can either have a mastectomy or you can preserve your breast. We don't have one good level 1 trial of comparing radiation to surgery in this country. We lack clinical trial participation in this disease. Finally, we have controversial and significantly different guidelines that are confusing the healthcare providers. We have the U.S. Preventive Services Task Force that says it's actually harmful to screen, grade D. And over at American Cancer Society, it says begin to have the discussion for high-risk men at the age of 45. We don't have that in lung cancer, or in breast cancer, or in colon cancer. So it is because when we don't have good evidence that people do very different things. So it finally leads itself to a lack of multidisciplinary approach. I am an oncologist who treats and specializes in breast and prostate and head and neck cancers. We have a multidisciplinary consultation team in breast and head and neck where you meet the radiation oncologist, the medical oncologist, and the surgeon at one time, and we as a group come together for your best treatment plan. We don't do that in prostate cancer. Many men see the urologist, and they never see a radiation oncologist, and so they don't have a discussion together. These are exceptional barriers to prostate cancer education and screening, but we can overcome it, and it really is what Mr. Farrington says. You have to be informed and educated, and it does require a little bit more time, but it can be achieved. Because of the U.S. Preventive Services Task Force, we have decreased screening rates across the country. This is from National Health Interview Survey. In every age group, we have a decrease in screening. And to respond to the task force guidelines, the Disparities Elimination Advisory Committee that I'm a part of, that community activists are on, as well as prostate cancer survivors, we decided we wanted to respond to the task force, knowing they did not have evidence to include high-risk men in their screening guidelines. And we thought the first way to respond was to develop a consensus statement, and I took on the task of developing this consensus statement. To have this consensus statement have any value, we knew we had to make it credible. So we enlisted support of leaders in the field. We knew it had to have a diverse coalition, not just self-serving urologists and radiation oncologists, but it needed to have epidemiologists and primary care physicians and community activists on it. We also knew it should have support of credible organizations, and it should be data-driven. So let me just say that our coalition members, one of the first ones is Dr. Gerald Andrioli, who is the chairman of the urology department at Washington University. He is a previous PHEN speaker, and he is the principal investigator of that study, the PLCL study, that did not include sufficient African American men. He has said all along that this study had inadequate representation of African American men, and a task force should have never included African American men in those guidelines. We have other people, though. To make this important in the St. Louis area, we have urologists and internists from other healthcare institutions because we wanted this statement to rise above healthcare affiliation so everyone would buy into it. And we also have the chief medical officers of our federally qualified health centers as part of it because we wanted them on the front line. Our sponsors are the United Way of Greater St. Louis. They helped to fund our project. But also important was the American Cancer Society at the national level because we wanted all of our educational material to go through their medical accuracy review team, and it did. So their logo is at the bottom of all of our educational materials. The Mound City Medical Forum is that round circle in the middle. That is the St. Louis chapter of the National Medical Association, and the St. Louis American is our African American newspaper that reaches over 250 people weekly. The goals of the Prostate Cancer Coalition are to specifically address the U.S. Preventive Services Task Force Category D rating for high-risk men, to provide education to healthcare providers. Now, this is why I think I'm up here. We just talked about how there's been a decrease in screening rates across the United States. And though we can go to churches and we can go to health fairs, if men go to their doctor and say, I want to have a PSA screening, and their doctor says, we don't do that anymore because the task force said that we shouldn't, then that's probably it because the patient's not going to have a long fight with their doctor about this. So we knew we had to provide a re-education of the healthcare providers. And we want to provide education to community about prostate health and screening to clarify the confusion. So our petition is in two forms. We had one that went out to the community that they could click on and endorse, and then also to healthcare providers. And our petition was our consensus statement that was laid out with all those coalition members at the bottom of it where they signed their name. And just to give you 3 pieces of the data, because I said this was data-driven, because we wanted healthcare providers to stand up and look at this and challenge the thinking. The first piece of data is the age-adjusted mortality rates from 1975 to 2012. In green is the African American mortality statistic. Notice in 1975, it was about 55 men per 100,000, and it was steadily going up. In 1993, it plateaued and then began to go down precipitously every year and continues to go down at about 3.7% per year. First, I want you to see the width in those curves because the blue is white American men. So this is where you see the statistic of 2.4 times greater mortality in African American men than that blue curve, which is white American men. So in 1975, it was going up. 1992, plateaued, and then going down. So everybody should be asking, what happened in 1992 and 1993 where we have a drop 3.7% a year annually for the last 25 years? Everybody should be asking that question. Well, we talked about Dr. Freeman yesterday frequently because he is a giant in healthcare disparity programs and in research. Dr. Freeman asked this question over a decade ago. He said, why is survival increasing and mortality going down in African American men and white men? Why is that drop? Because that's great, but what's the cause of it? So he looked at what we call the incidence of metastatic disease. These are men who are presenting with metastatic disease. And in 1980, it was about 70. If you look at the left of the panel, these are white males, about 70 per 100,000. And then look what happened in 1990. It began to drop. So the men presenting with metastatic disease began to drop significantly and has dropped every single year since that time. 25% of white men in 1970 and 80 were presenting with metastatic disease. Look to the right of your slide. 165 to 70 men. Now that's a different number. Didn't I just say 65 white men per 100,000? African American men presenting with metastatic disease in 1980 is what? 165 per 100,000. Think about that statistically. What did I say in the beginning? 50% of African American men were presenting with metastatic disease. Now look at that drop that occurs around 1993. So in white men, as well as in African American men, men presenting to their doctor with disease that had already spread out to their prostate, to bone and liver and lung had dropped significantly. This is Dr. Freeman's work. His conclusion was it looks as though PSA that was introduced in 1993 made a stage migration shift of men presenting from metastatic disease to local regional disease. And this happened regardless of race, but the mortality has gone down and distant metastasis has gone down. So let me bring this home. Here's prostate cancer 5-year survival in green. Just look at the green bar graph. What is the 5-year survival if you present with metastatic disease in 1981? 33%. What is the 5-year survival in 2011 if you present with metastatic disease? 28%. I'm sorry to say, but we have not made great strides in improving the 5-year survival in metastatic disease. It's too late, but we've got great therapies coming, so hopefully that statistic will rise. But where have we really made the difference? In local and regional disease. Our therapies are better, and Dr. Etzioni did a great job yesterday of saying 30% of the improvement in survival is in PSA, 30% of improvement is also in therapies, and she thinks and has some thoughts about where the other improvement is. That was the data in this consensus statement. So we have now taken this consensus statement and a lecture series to grand rounds to medical society meetings in St. Louis, to the annual Academy of Family Physician retreat, and we also have it in physician newsletters. We find this incredibly important because, again, we have to change the mindset of the primary care physicians to begin screening high-risk men. Our Prostate Cancer Coalition also has a website. We have a homepage. The homepage has an event calendar of where anyone can go and get free health screenings for PSA throughout the month. In addition, we have printable educational materials. We have a prostate cancer resource guide that's over 50 pages long. That's anything and everything you would ever want to know about prostate cancer and where to seek treatment in the St. Louis area. In addition, our petition is also located on the website. We have an ongoing media campaign. We have billboards, over 20 in those high-risk zip codes that I showed you earlier, Metro bus ad, as well as newspaper articles that we do routinely in the St. Louis American. We do radio shows, and we have a podcast, and a Facebook and Twitter page, and I still don't know how to do my Twitter. This is a few slide pictures of our media campaign. This billboard is on I-70, which is our major interstate going through North St. Louis and North St. Louis County, and our church campaign. We are attempting to go to 25 churches by the end of the year. We're halfway there. Dr. Bullock, who has been just amazing in this area for over 30 years, is my partner in the church campaign, though we have many other people who are ready and willing. And most interesting is our RX outreach or prescription outreach partnership. Prescription outreach is a nonprofit pharmaceutical business that is completely directed to low-income individuals. You qualify if you make 300% or less of the federal poverty level. They offer over 500 prescriptions at reduced costs. They have agreed to put our educational material in all of their prescriptions. These are mail order prescriptions. So in Missouri, that reaches 2,500 individuals. Since this is a St. Louis-based pharmaceutical program with a national footprint, if we put it in all of the prescriptions, we will reach 44,000 people, and most of these prescriptions are every 3 months. So these are 90-day prescriptions that are filled. So it is possible that someone would receive this healthcare information 4 times a year. We are most excited about how we develop and assess this program. So what are our stressors? Fiscal weakness. We have constant funding pressure because as physicians, we're just not good at fundraising, and we have to learn how to do this. We have a weak internal capacity. Most of us are volunteers. We have few salaried employees. And human resources. It's easier to do a lot yourself and not to spread out the work among others and ask them to come on board. And then, although we have a pre and post survey for physicians, we need to be able to measure our impact in the community. So for the panel, some of the questions that I think we're going to have to grasp with is how do we address issues, healthcare issues in a population distrustful of the medical community? How do we educate the community and providers when data is insufficient and confusing? How do we collaborate and not reinvent the wheel? How do we maximize funding and respond to fiscal pressure? And finally, how do we improve impact and measure outcomes? Thank you very much.
Again, another round of applause for our wonderful presenter, Dr. Lana Hall. As I mentioned before, Dr. Hall will be joining the panel, but I do want to give the audience just a couple of minutes to ask what I'll describe as clarifying questions. So not so much to engage in dialogue, but if there was something about a specific slide or point that she made that you want clarity on, now is the time to ask that question. And again, I promise I will have copious time for an overall discussion, but Dr. Hall is here to answer any clarifying questions that any of you may have. Please.
So is the takeaway on PSA screening that PSA screening was effective in reducing the rate of metastasized cancer?
Yes.
So it's successful.
Yes. Okay.
Yes, Paul.
So that's legislation. In Public Law 10343 was a mandate. It was part of the National Revitalization Act, and it mandated that there was inclusion of women and also minorities on clinical trials. And they had a separate mandate in that legislation that phase 3 studies, these are the studies that are comparing two therapies to determine which one is more effective, so it will become a standard across the country. It demanded that phase 3 studies have enough representation of minorities on clinical trials so that we could perform a subpopulation analysis. So this PLCO study that was used as level 1 evidence against screening in itself had significant problems that we talked about at length yesterday. But ultimately, the real problem for high-risk men is they were not included in that study. Therefore, they should have never been part of even the guidelines that had come out from the U.S. Preventive Services Task Force. So that is what was so remarkable to all of us, is that you have to have evidence in order to make policy, and if you don't have the evidence, then you certainly should not withdraw something that has statistical evidence of being life-saving. And we had that evidence in the reduction in mortality in African American men in the PSA era.
Sir?
We have a microphone. If you give me a moment, I'll get to you.
Well, that is the problem. The PSA test is an organ-specific test, so it's giving you a snapshot of the health of the prostate. The PSA does not tell you if you have prostate cancer. What the PSA tells you is if you may need to investigate an issue with an abnormal level a little bit further. So the PSA is not considered very specific. There can be a lot of false positives because the PSA picks up prostate gland, and it might be elevated simply because your gland is enlarged, or you might have a little bit of inflammation. That is why there are additional tests, like the percent pre-PSA, the PCA3, which is called the prostate cancer antigen 3 test. And these tests are more sensitive at distinguishing that, or an elevation in a PSA that may be due to prostate cancer as opposed to benign causes.
I've been told that if you get a biopsy, then you risk infection. Is that true?
It is true that you can potentially have infection with a biopsy, though that rate is very low, and there's ways to reduce it.
Okay, thank you.
You're welcome.
Other clarifying questions? Okay, very good. What I'd like to do at this point, actually, if Dr. Hall would stay up. I don't know why she wants to get away from us. But again, we have a number of people that I'm going to invite up to the stage now to serve as part of our panel discussion. And as they come up to the podium, I'm going to begin the introduction. So I'll just ask you to come up now. And as you're doing that, I'll just read a couple of comments about each of you. First of all, Ms. Golden Bethune-Hill, who is a registered professional nurse with 50 years of healthcare experience, who retired in 2010. The Executive Vice President of the Riverside Health System and President of the Riverside Regional Medical Center. And that's what we do.
Hello, everybody.
We also have, as was mentioned before, Dr. Jelando Jackson. He serves as the chair of the Grand Social Action Committee, director for the Central Region Boulay, and immediate sire Archon for Epsilon Theta Boulay of the Sigma Pi Phi fraternity. Dr. Jackson is the Velas Distinguished Professor of Higher Education and the Director and Chief Research Scientist for Wisconsin's Equity and Inclusion Laboratory, and that's at the University of Wisconsin-Madison. I'd also like to introduce Reverend Tan Moss. He actually was born and reared in Havana, Florida, earned a Bachelor of Science degree in Political Science and a Master's degree in Applied Social Science from the Florida A&M University and a Master's of Divinity from the Interdenominational Theological Center in Atlanta. He was ordained in itinerant, thank you very much. Okay, elder in the AME Church in 2004, and currently serves the Greater Grand Memorial AME Church. Michael Shaw, the director of the Office of Urban Male Health for the County of Alameda in California. His primary focus is to address inequities in healthcare services for historically underserved males. He also developed multiple health service models that target communities of color, at-risk juveniles, and justice-involved youth and adults. Dr. Shelton, Colonel, retired USA, President and CEO of Shelton Professional Services. He's a 13-year prostate cancer survivor and a very, very strong advocate for PHEN. Dr. Shelton was appointed by Governor O'Malley to serve a 3-year term as a member of the Maryland Council on Cancer Control and was reappointed under Governor Larry Hogan. Dr. Shelton co-chaired writing the Prostate Chapter for the Massachusetts Comprehensive Cancer Control Plan Executive Summit. We have a wonderful panel. Please help me welcome them all. So, here's what I'd like to do. I'd like to actually ask each of the panelists to tell you a little bit more about the work they do by addressing this question. I'm going to start, if I may, Reverend Moss, with you. And I'd like you to talk about your experiences providing education about prostate cancer issues in Black communities, and if you would, highlight specific challenges that you've seen. And of course, I invite you to address that question from the faith-based perspective.
Thank you so much. Good morning, everyone. As just recently said, I pastor the Greater Grand Memorial AME Church in the city of Jacksonville, which includes Duval County. Duval County has a population of about 900,000 people, and 30% of those are African Americans, 44% of those are males, which is about 118,000 people are males. About 48 to 50,000 of those males are in the category where prostate cancer is a potential for us. In the city of Jacksonville, there are 1,600 churches, and about 53% of those churches are predominantly African American congregations. So considering the historical relevance and the impact and the influence of the Black church was displayed in the lives of African Americans throughout the African diaspora, it's a natural conclusion that the Black church in Duval County, in other metropolitan communities and rural communities, has a tremendous potential for disseminating the message concerning the prevention and the treatment of overall prostate cancer awareness. Thank you. One of the primary tenets of practically every religious belief system and practically within the context of the African American church is the concept of faith. Faith in sense of not simply believing with a great deal of hope that something will happen before it does, but faith that embraces the sense of knowing that the provisions have been made for healing, and then trusting God to manifest it before it actually happens. Scientific studies conducted by numerous researchers have found a strong relationship between people's reliance on faith and various belief systems and positively increasing the ability of patients to effectively cope with their conditions. So faith is very important in the African American church, in the faith-based initiative in helping not only disseminate that information, but also helping people through the process of dealing with diagnosis and treatment of prostate cancer. The Gregory Grant Church has participated for the last 3 years in hosting the annual Prostate Cancer Symposium, and we've had tremendous support from our community, tremendous support from our leaders, both our elected leaders and our governmental leaders in the city of Jacksonville. We initially became involved with Prostate Cancer Symposium through the relationship between our bishop and Mr. Farrington. And our bishop has been one of our speakers for the symposium, and he's also given us authorization to bring this initiative to our 6 annual conferences, which includes Florida as well as the Bahamas. We have had a number of men, I think about 11 men in our congregations who have participated on the panels along with their caregivers in talking about their experiences, and considering all of the medical professionals that have talked about prostate cancer and given us all of the information concerning treatment, diagnosis, prevention, all of the alternatives. It has really been the impact of those who have been survivors of prostate cancer that have really tremendously impacted all of our symposiums. One of the things that we attempted to do this year, and we were very intentional about it, one of the speakers that we had that talked about faith and healing was one of the pastors from our white congregations, because we believe that not only is this a cultural issue in the black community, but it's also a community issue. When I say community issue, I mean the broader community, everyone in the city of Jacksonville. So we had one of our pastors that was part of our ICARE organization, which is a justice ministry, to come and to speak, to create awareness in some of the other congregations of diverse culture. One of the challenges that we've had is kind of been defining our success by virtue of those who attend our symposiums. And what we've come to understand is that we've got to think about defining our success based on the number of people that we actually impact and touch with this information. So one of the things that we've attempted to do is to work with all of our other churches outside of the African Methodist Episcopal Church in terms of working with their various health ministries, their health fairs, to get that information to them on an ongoing basis, so that even if they're not at the symposium, we at least get that information into the hands of men in our community, and then track the number of men that we put that information into their hands and follow up with periodic information throughout the year as we attempt to disseminate this information holistically throughout the community of Jacksonville. And so, as I said earlier, faith has a tremendous impact in helping people recognize the possibilities of not only preventing, but being healed through prostate cancer. And so we are just extremely honored and proud to be a part of the PHEN network and to host these symposiums.
Outstanding. Dr. Mal, thank you so much. As you'll notice, I'm going to give each one of the panelists 5 minutes to talk about the question from their particular perspective. I'm going to ask each of you to please speak into the microphone for recording purposes to make sure that the audience can hear you clearly. Dr. Shelton, if I could go to you next, I'll repeat the question just to make sure that we're clear. I'd like you to talk about your experiences providing education about prostate cancer issues in black communities and highlight specific challenges that you've seen in your work.
Yes, as we mentioned, I'm the regional survivor, prostate for PHEN, the coordinator, and as we just spoke about, one of my jobs is to go out in the community, and what we've been doing is working with the churches in the community. Also, as you mentioned, Mark, I'm also appointed by the governor as the coordinator on the Maryland Cancer Council for trying to reach the community in the Washington, D.C., and Maryland area with the churches and the outreach into the different areas of trying to bring the message about, the importance for the African American men to be screened for the prostate cancer. As you mentioned, I'm a 13-year prostate cancer survivor. I've seen firsthand as a physician and also as a family member the devastation from the metastatic prostate cancer. My uncle died from metastatic prostate cancer, went from 200 to 99 pounds. Some of the obstacles that we have is just in the outreach and trying to get men to understand the importance of getting the screening. And we've talked a lot in the last 2 days in regards to the women power. And studies have shown that 65% of men that have been diagnosed with prostate cancer, they found out their diagnosis by being coerced or beat up by their wives or a significant other. One of the things I think that we need to do, we probably need to try to go and have the women be part of our mission to educate men. And by saying that, I mean we're going out into the beauty salons and putting information up, that please have your men in your family, your husband, your males in your family to take heed and understand the importance of coming out and being screened for prostate cancer. And so these are some of the obstacles, just trying to get the message out and getting the men to understand the importance. It only takes, as Clint was mentioning at Howard University, PHEN is working with Clint in the Burnside at Howard University. Take 10, it only take 10 minutes for the exam, and I think we need to get the men to man up. Okay, I'm a little guy. I'm not going to hurt you. Okay.
All right, thank you so much. Okay, next up, Mr. Michael Shaw. Again, I'll repeat the question for you, Michael. Talk about your experiences providing education about prostate cancer issues in Black communities and highlight specific challenges that you've seen in your work.
Good morning, everyone. Good morning. 26-year public servant. How do I discuss this in 5 minutes? I'm going to try by telling you a story. I'm going to tell you a story about an Ethiopian proverb that says, when spider webs unite, you can tie up a line. That web has become a partnership, collaboration between the UCSF Helen Diller Family Comprehensive Cancer Center, based in San Francisco, the faith community of all denominations. Thank you. And the community of African American men survivors, and the public health department. That collaboration is what has become a model. It is interesting that PHEN wants to know what has worked and what hasn't worked. Tom and the PHEN crew, I want you to know that your model is working. It is 3 years ago that I discovered PHEN by accident in trying to figure out what we do in Oakland, California. We were going into churches and we were doing education, and we decided with the university we would do screenings. The first year we screened 25 men because we used the digital, I believe because we used the digital record exam. The second year we educated 300 African American men in a church and screened 125 right after the symposium. We went from the pulpit to the back of the church for the screening. And then this year, our third year, we educated around 125 men. And there were some challenges in getting numbers to the church. But the beauty of it was we screened 85 out of 125. So 300 we educated, but we didn't screen as many. So I think the model is beginning to shape into being an effective model. There's another piece to this. So we decided we're going to do education, we're going to do screenings, there must be follow-up to those screenings. There must be comprehensive follow-up. there must be a medical home for anyone who doesn't have health care. We decided that we would partner with other divisions of the health department to ensure a medical home is provided to any man who doesn't have one. And I want you to know the spectrum of these screenings went from unemployment to a janitor to a PhD to an MD. That's the level of screenings and the way we cross the African American community. We did all of that, and the flagship of this work became an African American support group for prostate health and awareness. I've been listening to my colleagues, and many of the pieces of this puzzle that they're putting in place, we put in place in California. But it's so much that needs to be done. And I've only been given 5 minutes to talk about it. So I want you to know, replicating this model is critical. I think it works. I'm working with the Cancer Center to actually formalize, is this working? I hope we're able to do a partnership. I want you to notice I haven't named a person, because to name one person and lift them up would mean that I not lifted up everyone who was involved in this. And this would not have been done without everyone involved. When spider webs unite, you can tie up a lion. That lion was prostate cancer. The target was the African American community. And I'm hoping I get a chance to talk about more of the details of the support group, which is our flagship, the challenges we're bringing in churches, and the politics of a public system engaging with community at a level in which community was driving our engagement. Thank you.
Golden Blue Hill. Should I reread the question?
I think I have it. Thank you. Good morning still to everyone. It is certainly great to be here. And as Dr. Hall was speaking, I recall very much so Tom speaking several years ago when preventive services came out with 40% reduction in mortality rate since the advent of the PSA. And that just resonated so much with me, I had to touch him, and I'm going to pat him for singing it again. I'm approaching this from 4 different ways. First of all, caregiver. My husband told you yesterday he was diagnosed in 2002. We were not married at that time. Subsequent to that, we both lost spouses and we connected later, but we've been friends forever. And we communicated with his diagnosis, and I'd like to think I had a small part in helping him to do what he needed to do as a good friend. And certainly caregiver, as he was re-diagnosed, I was very much a part of his life at that time, and I was involved in that. But my dad had prostate cancer more than 30 years ago, and thanks to the PSA, he's still alive today and just turned 99 on Friday. There are stories like that that can be told all over. I lost an uncle to prostate cancer, but he was 92. He had many other issues going on. He didn't die from prostate cancer, but because, again, he was checked early and had treatment, he lived to be 92 years old. I'm also an advocate. I'm a co-founder of the Hampton Roads Prostate Health Forum, an organization to promote awareness and education of prostate cancer in Hampton Roads. And I think you heard yesterday, Virginia Beach, Newport News, Hampton, Virginia, Norfolk, Portsmouth, and we have Terrence has been involved with us, and Lawrence is here. Lawrence Davis is very much involved, and they're champions also as a part of this network. I'm also an educator, obviously, by nature of being a nurse. You educate all the time. And yesterday, taking a taxi to the mall, I said to the driver what I was here for. And he said, you know, I have not had that test. I changed my doctor because the doctor was telling me all this stuff and getting me confused about it. After less than 5 minutes in the ride, he said, you know what, you've convinced me. I'm going to go back and get that test done. Right. So we are constantly. I'm also a provider. When I retired from my job where I got paid, full-time volunteer now, I opened a free clinic in our area because I was very concerned about the uninsured. The free clinic takes care of people from primary medical care, dental care, and we provide medications. And I volunteered at that now for almost 16 years as the executive director, and my husband's also partnered with me in doing that. Charlie mentioned to you when he spoke yesterday, for those of you that are here, that we're doing something every 6 days with prostate cancer. It might be a TV show, a radio show. It might be an educational program. We work with PHEN, certainly on Paint the Region Blue. And we have now about 30 churches that are engaged in Paint the Region Blue. I remember 6,000 ribbons last year, and most of them were made in my home with many of my sorority sisters helping me and my link sisters. And you know, it's been said over and over again, the divine line, getting people involved. These groups want to participate and want to help. And I found it to be most helpful in educating my sisters and the different organizations as they go out and they can spread the word. And we have a saying, each one reach one. We have an annual event at a church in Hampton. Hampton has the highest mortality rate in our region, one of the highest. Portsmouth is another one, and Lawrence is a champion there. Terrence, champion in Norfolk, where we have other high numbers. We do involve the faith community. I'm a deacon in the church, Charlie's an elder, and we believe in that faith model, but we say faith and works. And I also say you cannot glorify God and do his work if you're sick. So we spend a lot of time using the scripture to help people understand how important it is to take care of their health. And we have been very successful in doing that. At first, we started with a donation of our own to have a ministry for health in our church. And for Men's Day, and when we talked about prostate cancer, we brought everything out. We put boutonnieres on men, and we did everything we could to have them talking about Paint the Region Blue, and on Father's Day, why it was important for them to be tested. And we do the prayers, and we follow the model from here. That's where we started with that, Paint the Region Blue. And we have, you know, I'd love to see Hampton Roads one day just go completely blue. They changed the lighting now in the different cities for us, but we need to do a lot more to make that happen. And we try to provide a champion in each community. One of the things that we do a lot of is when we have the programs, we always have an educational program for screening. We don't do screenings without doing the rectal exams. And my husband, now I'm very comfortable with it too. I wasn't at first, but very pointedly says to the men, you know, you don't wait until you're bleeding or something's falling off before you go to the doctor. He's very direct in talking about what men need to do and about sexual dysfunction. He talks very clearly with the men about what that means and what you can do about it. And I believe that that's been most successful for us in getting men to come out and to get their attention. We also make women come. We have them bring their wives, and the women will ask more questions than the men very often. And not only will they ask the questions in the open session, they'll grab us after the meeting and say, please talk to my husband again. He needs to see somebody. He needs help. Because the men are ashamed to tell you that they're having a problem. And after what you heard today with the castration, you understand now more what we have to do to help our men get in clinical trials. If they hear that, what do you think they're going to say? I don't want you to touch me. I'd rather die than to have that happen to me. So we've got a lot of work to do to change that. No, we don't do that anymore. I'm saying we have a lot of work to make sure people understand that. But that is the story that's being told from years ago. And we have to make sure we don't continue to carry those stories. We've had a 5K run now for some time and walks, and we're working with Zero this time with Urology of Virginia to do an even bigger event at the zoo in Hampton. And I'm also excited, and I guess my time is coming close, that the Tides, which is the farm team for the Orioles, Ken, decided to do something. Their general manager wants to be a spokesperson for prostate cancer. So they're collecting, I think it's a penny for their gate, and they're giving us a donation. That donation last month was like $7,400, and that was just within a month's time that we were able to get some money. But they turned their bases blue, and they also had an event there that was screened at the ballpark in one of the suites. And we had 6 doctors show up from one group to come out and do this. And it was just excellent. One of our hospital systems did the screening, and they want to make that an annual or semi-annual event. And we ought to do that all over. And we've used athletes. We've used, certainly in our area, 757, we have a lot of guys that have made pro football. They will come back and be a part of our events. That helps us to get men out. Because when you say you have a famous ball player, they're going to come. Again, I've said a lot already, and I guess it's time for me to stop and let somebody else talk.
Now, I'm actually going to take a slightly different turn here as I invite Dr. Jackson to make some comments, because as you've heard, Boulay has a very large footprint across the country in terms of numbers of men that could possibly be reached by a partnership with them. So Dr. Jackson, if you would, I'd like you to talk about what Boulay can do to carry forward across the various chapters that are involved. What can we do through a partnership with you to advance some of the things we're trying to do here? And where do you see the impact of Boulay's involvement as you begin a partnership with us in this initiative?
Thank you. As mentioned earlier, I'm the chair of the Grand Social Action Committee. And Grand Social Action is our outward-facing work that has a focus around our community engagement and transformative outcomes and work that we do in our communities. The Boulay committed to social action shortly after 1904 and its founding. And under the current leadership of Grand Czar Coleman, who you heard from earlier, the commitment has been increased. He's increased the Grand Social Action from 4 subcommittees to 10 subcommittees. And 2 of these new subcommittees have a particular focus on health. You mentioned earlier about the healthy lifestyle effort, but we also have a focus, one around tainted drinking water. Our communities are affected in our daycare centers and schools, where we have young people drinking tainted water that has lead in it that not only impacts their ability to live healthy lives, but to learn. And that's one of the efforts that Boulay wants to give some voice to as well. The efforts that we have in place, some of which you heard already, have a focus on preventable challenges that impact blacks in general and black males in particular. We have certainly desired to, over the next couple of years during Grand Czar Coleman's administration, get root more deeply in our communities and be a bit more broad in our scope with the work that we have been doing and thinking a bit more strategically in that way. So we've committed to increase our efforts and to push these works out in a more broad way, to be very strategic with advocacy, but also through some technological platforms that we have available to us. You've heard about some of our partnerships earlier. One of the partnerships I don't think was mentioned is that in the recently launched Black Men's Health Survey, which was launched yesterday here at CBCF as well, we have partnered with them through one of our subcommittees because, as mentioned earlier, there's a history of mistreatment as relates to black males, trials, study, and research, and we want to be very helpful in partnering there because it's a landmark study, and it's a key study that will be able to provide data and good information, I hope, for those that are studying in this area. And then it was mentioned about the partnership that's in place with Thomas Jefferson University to be a partner with increasing those black males that go on to medical school. And we see great benefit in that, not only because of the linkage to our founders, but because you've heard data earlier today that we are decreasing our participation in that space, and that's an area too we desire to work with. We feel that we have a unique capacity to be able to pull together some of the key leaders in our communities because the way the Boulay is structured, it's a graduate fraternity, so within our fraternity we have all the other fraternities involved, and likely the key leaders in most of our social and civic and corporate organizations. And so it allows the ability to share resources, share knowledge, and share networking in some pretty unique ways, which we're being more strategic about. And the partnership here, an emerging opportunity with PHEN, is one that we are certainly excited about and look forward to learn more ways throughout the rest of this evening and future conversations on how we can be a bit more helpful there as well.
Outstanding. Thank you so much, Dr. Jackson. So, I hope you now have a sense of the quality of this panel as it relates to our discussion here about meeting the challenges of educating and mobilizing Black communities on prostate cancer issues. What I'd like to do now is literally engage a cross-panel discussion, and then I'm going to start to bring any questions that you have into this discussion. What I'd like to do is actually go back to our presenter, Dr. Hall, and ask you if you would start the discussion by addressing this question. Given your experiences and observations, considering Dr. Jackson's comments about the potential and, of course, clearly powerful involvement of Boulay, let's talk about gaps. I mean, we talked about all the different things that are already going on. Is there anything that you have not heard, or any things about what you heard that represent areas that we can delve into a little bit more deeply? So where are those gaps, and what comments could you make possibly on how to address those gaps?
Then you told me you were going to answer that. This is good.
Well, just last year, we completed a 25-item questionnaire looking at barriers and facilitators to participating on clinical trials. We looked at several things: your religious beliefs, your educational level, income level, your baseline information about clinical study. And then we also looked at the significance of having a healthcare provider, and then distrust in the medical community. What came from that survey, which was mostly patients who had either prostate cancer or colorectal cancer, was a significant distrust in the medical community. Significant distrust that became more significant if the income level was less than $35,000 and if education level was less than 12th grade level education, not a high school graduate. The same with religious beliefs being at cross purposes to research and healthcare. So it wasn't, so this is an interesting concept. Research was thought to degrade the sanctity of God, that who really has the right to determine health, not your healthcare system, not the science, it is your prayers and your beliefs and your relationship. And this has been very interesting because what it's been manifesting is that a lot of people, we find when they don't quite understand what's going on with their bodies, they may not show back up, and they have told our nurse, we're just going to pray on it. We're not going to come back. Just going to pray on it. So what I have seen in my career over the past 20 years are people who have not completed treatment in the School of Medicine, and who have not shown up for surgery after having a diagnosis of breast cancer. And we see that in delays in men getting treatment for prostate cancer after biopsy comes back positive. And I think we have to address that this distrust and also using religion not in a way to support our healthcare services, but as a way to fall back and say, I'm not going to participate. Now, let me just make this clear. If someone was in here with chills, fever, and a cough, they'd have no problem saying, I'm gonna go get some antibiotics if I have pneumonia and taking it, and also praying that they get better. So we need to be active participants in our healthcare, even in areas where we don't understand as much. And that's when the physician needs to spend more time, and we need to have patient navigators and support services on every level. So I would say I really want to engage our health ministries in helping us to carve out messages to make sure that we don't fall in the wrong box of saying, let's just hope for a miracle, as opposed to being active participants and keeping ourselves healthy.
I'd actually like you to jump into this, and then we'll come to you. Okay, sure.
All right, thank you. I think in our faith tradition, this idea of faith in healing is profoundly demonstrated in the biblical story of the woman with the issue of blood, who had been sick for 12 long years and had sought different types of remedies, and I'm sure she had prayed about it considerably. But it was not until she actually put her faith in action and did something and went to that place where she could get cured and get healed that she found her healing. And so this model, this PHEN model for us, not only emphasizes faith in terms of our prayer and accessing God and for God to heal, but also being empowered to go and get treatment, get testing, to do those things that are necessary in order for us to bring that healing into fruition. And so for us, faith and action works together to bring about the healing. In terms of things that we're doing to kind of address some of the gaps that we found, one of the things that I heard yesterday was the issue of transportation and how many people don't avail themselves to medical treatment and care because of a lack of transportation. And so one of the things that we're doing in our ministry is to actually provide transportation to those people who are in nursing homes, those people who are part of our homeless population, which is very significant in Jacksonville. We're actually going out and promoting the symposium and sending transportation there to bring those members of our community to the church so that they can avail themselves to the education. And this year we are attempting to have medical professionals there on site so that we can get the testing and the screening done as a part of that symposium. And then the last thing is, I heard yesterday, it said over and over that age between about 45 is when you begin to get tested. And someone, I think it may have been your husband, suggested that even 10 years.
We say 40.
35 to 40. But I believe that seed needs to be planted even earlier than that. And so one of the things that we want to do is access social media, hip-hop radio stations, televisions, to start planting that seed in the minds of young men, even in their 20s, of the necessity of taking care of their prostate health. And so I believe those are a couple of gaps that we want to try and fill as we are moving forward with this process.
Yes, I think Dr. Hall hit on a really critical point, and certainly one of the frustrations I felt even running a free clinic. When you have people that are not used to having health care, and I would say access to health care is probably a major barrier. I would say major. When you're not used to having health care, you're not in a routine, just as we talked yesterday about a routine of going to get your checkups. You're not in a routine of taking medications, of going to the dentist. And we have no-show rates in our environments. And you mentioned not showing up for surgery. One of the things we had to do in our clinic, when we had doctors there, some that we pay for and many that volunteer waiting to see people, they don't show, that's not good. So transportation comes into play, reminders, going to pick them up, but developing that trust right from the beginning. So in our communities of faith, one of the things that we do very often, I'll stand there and talk about Tuskegee experiment, Helena Lack, all of the things that people are afraid we're going to do to them when they come to our facilities, as it's been done with research. You're going to do something to me that I don't want. We have to get rid of those barriers that they think about all the time and get them to trust you. So you have to follow up with phone calls. You have to go out there and talk with them. The doctors have to meet them where they are, and the way we're asking them sometimes today to provide care, and you heard it yesterday from the gentleman from Duke, they're moving so fast that they will have another room set up for the patient because the doctor doesn't have time to talk with them. But we might need to have somebody else there to make sure they understand what we're doing. And we can't give up. We have to keep calling them, and I've committed to doing this. We've committed in our clinic, and I'm hearing that from many of you here. Follow up with those people that are not used to having here. Help them understand the value of what you're providing for them, and let them get to trust you just by being present with them. That makes a big difference in the world. If they don't show, call them up and let them know. We've had the police help us to go find a patient who had critical values, and the patient was so shocked that we cared enough. We've gone to shelters to give people medications. So I think, we have to work a little harder because we have to overcome the barrier of people not being used to having care. And I think we have to do all of that. So I say faith and works go together, and we have to help our people understand that, because you cannot glorify God if you're sick.
Now, as I invite some of the other panelists to comment before I open up the questions, I want to just say to Dr. Jackson, as you begin to think about how the Boulay may get involved with this, even numbers that you potentially access, hopefully these comments will inform some of the strategic thinking that you do as you begin to think about how you might want to begin. So, and I'll ask you as we wrap up if there are any comments that you'd like to make in that regard to what you've heard. Having said that, Michael, do you want to make any comments?
So, Mark, I just want to say this. A long time ago, as a public health official, I said that one day we will see African-American men in a museum. Now, I'm not playing. In Alameda County, we are 12% of the population. That is the kind of representation of the Black community in this nation. So we are often focusing on pockets where African-American community is the largest. The reality is that we're 12% of this country, that our congressmen and women and senators and public officials very seldom represent us. That's why we got this Black caucus. And this is why we got a congressman in this room who does. This is why PHEN is important to us. But I put this not out of data, but let's look at the realities of our community. Yeah, one day you're going to find Black men in a museum. And notice I didn't say Black women. Black men suffer from the most disproportionate health issue of all of health. Now, that said, the faith community is critical. Pastoral leadership is critical. This partnership with PHEN, Congressman Meeks, I really appreciate you. That's okay.
We'll let him know.
He's on this national telecast. Because this is a national issue. Without PHEN, we wouldn't be doing this testing. I'm connected with a multi-billion-dollar cancer institute. And yeah, they are willing to provide the testing, but I'm committed to making this an African-American community issue that we solve. I like how my sister kept using we. Now, all of that said is we got a lot to do, folks. We got a long journey to go. If you come to my office, you see African-American men lift up community, they lift up family. This does not negate the women of our community. But if we don't empower men to be the answer to men's health, then we're making a huge mistake, folks. That's my comment. I hope I get some response from it.
Excellent. Actually, I'm going to invite that response right now, because what I'd like to do is actually now engage the audience in this dialogue. So you've heard a number of the initiatives that are going on. You've heard the panelists identify some of the gaps from their perspective. What are you not hearing that you're experiencing about gaps? What are you not hearing about potential solutions? We'd love to hear from you.
Before I ask my question, I want to thank the panel because as a pastor in the African American community, I started getting information from PHEN when I started pastoring in 2008, 2009. I never came to one of these conferences. I figured they just have some people show up and do some talking. But the level of people that you've had speaking has been awesome. And I have it's kind of a personal question because I'm a cancer survivor, but not from prostate cancer. And so cancer awareness is very important to me. But one of the issues I'm having as an African American pastor, I don't have a lot of the resources that maybe some churches have. I'm in a low to middle income area, but my passion is to get the information out. And so since I retired from the government, my schedule is a little bit more flexible. And I want to know what kind of things can I do. I don't have a lot of active men in my congregation, but I'm in a community that has a lot of men who are in high-risk categories, and there's something, what can I do personally? Any suggestions, any encouragement? This is a personal question. Any encouragement that I can do to help my community? I met Brother Burnside yesterday. You're going to hear from me, right? Okay, we're going to talk. There's your name, right?
Bridgewater.
Bridgewater, you're Burnside. I'm going to take with you too. I talked about Bridgeside yesterday, but what can I do as an individual who has a passion for that? My father died of cancer. My uncle died of lung cancer, and so I have cancer throughout my family. So I know I am in high risk, but also have high passion for doing something. But I'm not sure what it is I can do to help my community.
Of course, I have some PHEN comments to make about that, but I'll let you guys.
Let me just say, you're automatically a member of our Survivor Network right now, and we will engage you to help us do a lot of things in your community. Okay. And we appreciate that. So don't leave until we sign you up.
And PHEN,
I'll be the one you'll be talking to, so just.
PHEN provides resources for those symposiums that Tom is suggesting. It's amazing resources that a church can actually get education, get screening at no cost to you. PHEN really believes and understands how churches work.
Make sure you understand my question. I get the information. I have the passion, but I need the resources to take that from me to my community.
That's exactly what I'm talking about. And I'm going to add that in my local community, the pastors came to me as a public health official and said we had an obligation. And if you want some help in working with your health department, I would be very happy to help you shape that dialogue and make that kind of bridging. Because it worked, and it's our money in these systems.
Please.
Hi. What Dr. Hall resonated with me, your particular issue about people not continuing with the with follow-up because of religious reasons. My uncle had prostate. Thank you. My uncle had prostate cancer. He was a professor, and he didn't try to get help until the bitter end, and he died. My daughter was diagnosed with Hodgkin's lymphoma, and I have a cousin who kept encouraging her not to get the treatment, kept telling her that you shouldn't put poison in you. My daughter had no symptoms all through college, and then when she, I gotta stand too. Okay. Okay. And my daughter wasn't sick until she had the chemotherapy and radiation, and understanding her additional risk as a result of her radiation to her chest. So my cousin, who had breast cancer, never had any treatment, did everything holistically because of religious reasons, and she died. So, but she didn't get sick to the bitter end, whereas my daughter was sick all through chemotherapy, through radiation. My daughter's fine now. So that's a big issue. How do you explain to people who are educated, know better, they see treatment too late or just not at all after a diagnosis? So that's an issue for me, it's been in my family. Thank you.
I think this goes back to a significant amount of legitimate distrust in the healthcare system. People would go to the hospital and they would not come out, or if they did, they were given a diagnosis because they were coming at the late stages of disease. And, or if you go back even further, you have 50 years of the Tuskegee experiment, and 30 years of having penicillin readily available and withheld in the Tuskegee experiment. So even though a lot of people don't understand the details of the Tuskegee experiment, they just know good things sometimes don't happen when you go to the doctor. This is why the patient navigation system is so important, because if you have a buddy, we have some in a community advocacy group called the Breakfast Buddies, for example, for women. So as soon as you're diagnosed, this buddy who is a survivor goes to every appointment with you to make sure that you get through your surgical appointment, your medical oncology appointment for chemotherapy, and you make it to radiation. We actually need that kind of support and encouragement to continue on, because I can't tell you how many people will go try to find sharp cartilage or some kind of water or something else to do rather than go through treatment because of underlying fear. And so I have recognized that I've got to spend more time with someone who has not been engaged in the healthcare system, because everything about it is foreign. Whereas for many of us, if we go into a great comprehensive cancer center with 10 floors, we think they should love it. There's nothing they love about that. Everything about it is foreign to them. So we have to remember that this is not a warm and fuzzy situation on any level for people, and we need to have navigators, buddies, and support groups that are lined up from beginning to end, no matter how educated you are.
Dr. Hall, I commend you on your presentation, and I commend your colleagues on the discussion. But Dr. Jackson said something earlier about healthy lifestyle. And will somebody comment on what are some of the lifestyle things that we should be doing to hopefully prevent prostate cancer, or to defer that day if it's possible to do it? And another comment I want to make, I spent 22 years on the Hill, and in the early 90s, we would ask people to come to the office, do you go to doctors? And it was amazing. The number of African-American men would tell us, no. They took great pride in not going to the doctor because it was a badge of machoism to not go to the doctor. And then we would ask them, well, if you had a stomach ache, headache, where would you go? To the pharmacist. And the pharmacist would tell you, take this and take that. And then the pharmacist would always tell us after, they would tell them to go see the doctor, but of course the guys wouldn't go. But they would go to the pharmacist. And that was an aside, but my main question is, healthy lifestyle, what are some of the things that we should be doing? And so forth. Would somebody comment on that?
Sure. I'll do the basics and maybe we can talk about it. Diet and exercise. So that's a big amorphous thing, diet. But a low-fat diet really, and a diet that in lean proteins, has really been shown to be important in several cancers. So let's just talk about the importance of diet in reducing colon cancer. It's specific. It is a diet that minimizes red meat and increases the amount of fruits and vegetables and fiber. And that significantly reduces your risk of colon cancer. Colon cancer is the third leading cancer diagnosed in men and women and the third leading cause of death. We've got an excellent screening tool. I won't get into it, but the point is diet helps, and it helps across. People say, should I diet or should I exercise? I'm always going to say diet first. And I will say that because having 5 to 7 fruits and vegetables a day and having very lean protein sources like fish and beans are always going to be helpful in reducing your cardiovascular risk. Exercise is next. We know that BMI, body mass index, over 25 is overweight, over 30 is obese.
are associated with 50% of the mortality that we see related to cancer. So we know that cancers of the pancreas, multiple myeloma, colon cancer, esophageal cancer, kidney cancer, breast cancer in a postmenopausal setting are all related to being overweight. So what allows us to have a healthy BMI? Diet and exercise. How much exercise? At least 3 to 4 hours of exercise per week, and it doesn't have to be a marathon or an Ironman. It can be walking. It can be walking. So a lot of people say, I started walking, but I don't lose any weight. You've got to modify your diet. So getting back to prostate cancer, it's the data has not been as clear as we would like it to be on the impact of diet and exercise and prostate cancer risk. But come on, cardiovascular disease is still the #1 cause of cancer death. We have higher rates of hypertension and diabetes. We are going to benefit from diet and exercise.
All right, we have a couple of questions on this side. This gentleman and the next question.
Right, we'll be there, and then we'll have to see if we have any time for the board, right? I'll see you.
Good morning. I am a third-year doctoral student at Morgan State University. I'm enjoying everything I'm hearing. I want to piggyback on a story that was just said and add my story to it. I believe that health literacy, which is my focus in the dissertation, health literacy and health behavior among men of color in undeserved communities, is the preeminent, the focus that I don't hear enough about. And as a doctoral student, I had to decide what did I wanted to do and what I wanted to focus in. So my passion is about men's health. So when I heard the gentleman say men's health, I got excited. The story, my brother is another one of those people who fall victim to what we call black men's disease. Black men's disease is not listening to your body, not paying attention to dynamics, and deciding that I'm going to do this on my own. And I don't need no one to tell me what's going on with my body. I'll just go to the store and get some Maloney, Maybe, I'll get some Pepto-Bismol. I'll do all those things besides going to a doctor. That was my brother's case. But to this day, because he listened, we saved him from colon cancer. And so the point of the matter is, it's about health literacy, it's about health promotion. And I have a strong belief that we get caught up on alphabetic soup behind our names. That's what I call it. Alphabetic soup does not mean that you're health literate. It means that you have acquired degrees and credentials, but that does not mean that you're health literate. So we need to make sure that we begin that conversation around health literacy among men of color.
Thank you.
If I could just comment, if you recall, I did bring that up yesterday. We're giving out all the information. People are not understanding it with the 12% rate. And one of the things we do in our clinic is to have a session with people on the questions to ask their doctor, how do you keep track of your health, and to try and promote literacy. And maybe that's another topic, Tom, as well as something on nutrition that people seem to be interested in.
And if I could just add to both the point that you made and the point that this young lady made, we've been talking at the Great Grant Church over the last several weeks about being contagious with our faith, and that sharing our story, sharing our faith with both believers and unbelievers. And I think that is such an important factor in impressing upon people that faith, prayer, believing that God can do things miraculously is so important, but also understanding that God has created all things, the wisdom of medicine and doctors, and all of those things are important. And so the PHEN model helps those who have gone through this process to share their stories with other people. And so they share those stories on a holistic basis, but also I think it has to be done on an individual basis, like with the case of your relatives, where someone who has had that experience can actually talk about their experience, talk about their faith, and how also their faith empowered them to get to the medical help and medical professional services that they needed in order to reach that level of ultimate healing.
Excellent, thank you. Please.
I'm sorry, but there is a case, there is a point that some people reach the point they don't want anymore, and as healthcare providers, we have to accept that that's what they want and let them go the way they want to go. So as hard as it is for us, people have a right to choose. And if we've done everything we can do to make sure they have the right information to make the decisions, when they decide it's enough for me, it's enough for them, and we have to respect that.
And it's called quality of life.
Yes.
Hello, my name is Althea Dixon, also known as Alfie. And I also am a champion, regional champion with Zero, and it kind of works with PHEN as well. Some of the same sponsors and everything. And we kind of go on Capitol Hill and help lobby for cancer research. And we meet with a lot of scientists and different caregivers. Well, today, not caregivers, today I am representing myself. I'm a caregiver. My husband is almost a 12-year survivor. And one of the things I found that really helped him with our faith, with going through everything and catching everything in time, is also education, learning about it. Like the first thing we read was the ABCs of prostate cancer. I mean, I just was just going into everything trying to find out about this. But one of the greatest things that helped him was mental health, the mental health thing. Families and wives and everyone, because it affects us as well as the man. He may have the physical thing, but it's kind of like alcoholism or something. The family suffers as well. So that's very important. With so many topics that you touched on with the diet and dark leafy green vegetables, all that, everything working together helps. And we really have to dispel a lot of the myths and get involved in these different case studies. Because if we're not there, if they don't have us to see what's going on, then how are they going to know? These cancer, when you look at prostate cancer, I don't know, I'm not trying to overtalk the scientists, but they're different forms. And maybe in this case, it's something, this one may be slow moving, this one may be fast moving. So you have to really do your specific, find out about yourself specifically and what's affecting us. And all these myths we just have to dispel. And there's a lot of help for our people and everyone, but we really have to get involved and just talk to the family. Even my little bitty grandson, am I going to have prostate cancer? They want to know about everything, but they know as a family we're approached it healthy, with a healthy way, and we're survivors. So.
Thank you. Sue McKinney from Krilla. A comment that Dr. Etzioni made yesterday. If you screen, you must be prepared not to treat. Combining that with the concern that Dr. Hall raised, that not treating doesn't really mean not treating. And we have to combine awareness following a PSA exam with lifestyle and dietary changes. That is part of the watchful waiting I think we need to incorporate so that people do that. I've authored a document for my company. We call it OFTEN, Optimize Prostate Health Naturally, which is a summary of the clinical trial evidence and recommendations for how men can take charge now. And it's free. Exercise is free. Nutritional changes are free. And they do make an impact. And there are several things I've picked up at this conference I'm going to include in that. But that's something we can do, and it's got to be part of the overall discussion.
Just, I think you can hear my voice.
We're recording.
Okay.
Wait a minute.
My name is Lawrence Davis. I'm from Portsmouth, Virginia, where more people die, some people say, from cancer than anywhere on the East Coast. Okay? I would say it's been a beautiful session we've had. Thank you, Mr. Farrington, for what he's doing. I'm behind him 100%. I think that you need, most people need to be educated more. I understand what you're saying about what your company has to offer, and it's nice, but personally, as a black man, it doesn't work. For me to sit and wait and watch for see, it doesn't work for me.
Okay, I've got to get this thing out of me. I was fortunate, very blessed, that Mr. Wesley Coleman, okay, the school he came from, Hampton University, which has the largest and most advanced proton center in the world, cured me, okay, from prostate cancer. And I want to say that if you have cancer, get as much education that you can. Get on the line, see what PHEN is doing, see what other doctors and cancer is doing, okay? And let them speak to you in a common language that you can understand. Because medical terminology doesn't mean nothing to me. When you say mortality rate, that sounds fine when I'm an educated person. But if I'm a guy on the street, when you say it's a death rate, okay, that's a whole different issue. And I take it in a different manner. Okay. But I want to say thank you for letting me address this, and I wish everybody would get more education about cancer, because your sister or daughter, I think it was, that had the breast cancer would have probably survived through proton, because proton doesn't go anywhere but to the cancer. Okay. Thank you very much.
Thank you, sir.
One comment here.
You know, I asked my doctor, why is it that black men have high rates of prostate cancer? And he said, man, I can't tell you. I said, is it genetics? Is it the food? Is it the water? But he couldn't tell me.
We don't know.
He couldn't tell me. So I guess as black men, we just predisposed to having high rates.
No, we are overstressed. We don't get sleep. And those two things, I believe, is driving cancer in our community. For black men, we are the most stressed men in this country. And it destroys our immune system.
Dr. Hall, would you get a comment?
I think it's multifactorial. I believe that it is our environment, because we do know that there are more aggressive rates related to social, economic, income levels and education levels, and therefore the environment. But there is some genetic influences, some very good research that's been done by Dr. Powell and others across this country that clearly show that there are some driver mutations that we see in African American men who develop prostate cancer that we just don't see in prostate cancer in white men. So the question might be, why did that develop? And it could be that it was due to something that needed to occur to resist something else years and years ago. But the point is, I think there's a genetic influence as well as an environmental.
Now, I'm actually not used to Artie Shelton sitting back down there so quiet. I'm just wondering, Artie, if you're sitting there wanting to get into this discussion.
One of the things, I go back to what, time is getting to be of the essence. But, the biggest thing that Tom says is about knowledge is the best defense against prostate cancer. When I was diagnosed, I'm an internist, an allergist, and an immunologist. And when I was told my PSA was 3.3, I was happy. Until my doctor said it was elevated from the previous year, from 2.0. So therefore, what I'm saying, had I had the knowledge of what PHEN is teaching the men in the community, that you need to know your PSA level and you need to be knowledgeable. Otherwise, because I thought it was fat and happy, and it was short and happy, until he said that, Artie, because you're at risk, and because of this two physician that did a biopsy, I was able to hear 13 years later. So we really need to learn a lot. Each individual needs to learn a lot, and that's what PHEN is all about. And one of the last things I need to say, Mark, since you asked me, is that probably had a lot to do with, I don't know if anyone's familiar with the Senate Resolution 529, okay? And this is important what Tom has done, where it says this is a Senate resolution unanimously recognizing that the occurrence of prostate cancer in African American men has reached epidemic proportions and is urging federal agencies to address that health crisis by supporting education, awareness outreach, and research, specifically focused on how prostate cancer affects African American men. And so therefore, we really need to be behind Tom, and we really need to go ahead and get these federal agencies involved in helping us fight against prostate cancer.
Mark, can I add to that? We also need to support Tom through the preventive health services by insisting that they use this as a mechanism to make sure their communications are understood. I think yesterday Charlie raised that. When they communicate their new message, that it would be reviewed by PHEN, who's connected to all the organizations, so that we would make sure it fits with what we believe people will understand.
So again, if you would, please help me show appreciation to this. Thank you all for your time and participation. I'm going to turn this over to Tom Farrington.
Thank you, Mark, and thank you all of our great panel members. You all did a fantastic job. Give them a round of applause. Well, this is, we're coming to the end of our 12th Annual African American Prostate Cancer Disparity Summit. It's 12 years, and we've come a long ways. As I sat and listened to the panel members discuss this issue, and we hear questions and comments within the audience, I will kind of echo what Congressman Meeks said, that we are the brain trust, and it's up to us to continue to look at this issue within the community, within our health centers, and within our academic centers, to make sure that we put forth solutions and ideas that's going to impact on our communities, who are the ones, which are the ones that's most impacted by this disease. So, and this brain trust, you know, is including our partners. It includes our pharmaceutical partners who have joined us to help us put our thoughts together. It includes our organizations who have come together to help us within the communities. And from my perspective, after 12 years, I'm pleased that we're making progress. We have made progress. I've seen the progress being made within the summits. I've gotten many comments from those who attended yesterday that this was the best summit ever, and how you're going to exceed this next year. Number one, I'm glad to hear it's the best summit ever, because we strive to make each one better than the next one. And how we're going to top this next year, well, I don't know, but we, I've got a good staff. Mark will help me with some ideas, Juarez, and I have to mention Dr. Kimberly Rogers, who's our Director of Education, who's not here with us this year. So I'll put them to work thinking about how we do better. And in addition to that, we're going to come out to our brain trust. We're going to come out to you all and say, what should we do better? And one of the ways that we can begin that process is by filling out the evaluation forms that you have. And give us your thoughts. And let us know how you felt about what we did today, and what you think we should do differently for next year. We'll put all that together and come out next year with something even better. And that's the hope. But, you know, I am so glad. You know, I take great pride in what we do. And when we do it well, I like to stick out my chest. And to have the presentations that we did yesterday, and to have those panel discussions, I feel great about that. And we, today, I feel great about what has happened today, because, as I said when we started, we have to put our thoughts and ideas on the ground to make them work. You know, they have to be at the grassroots level. My background is in computer science. I was an entrepreneur, ran software company, and you know, when I started this, I asked myself, am I qualified? Do I really know what I'm doing? and I keep asking myself that question. Is this working? Do you know what you're doing? So I keep working and keep trying, and with your help, we're going to continue to succeed. So I just want to thank all of you for attending. I want to thank those who tuned in for tuning in, and I want to ask you to come back again next year, and let's do better. And I want to thank our sponsors again. I can't thank you enough. I want to, let's give them a round of applause again. We can't do better if they're not with us. So we really thank you, and we want to make sure you know that we appreciate that. Also, I want to highlight our Survivor Network. When we, Mark pointed out that we have, actually, it's over 300 men and women who signed up as part of our Survivor Network. And when we are in the community, we really have to rely upon them because we can't have people all over the country. So I want to thank them. Just members of our PHEN Survivor Network that are here, please stand up so that people can see you and know who you are. And Deacon Ray Fuller just came in, and I don't know what the meaning of that is, Ray, because as I said, Ray sang. So I didn't know whether that means the Ray is supposed to close us out with a song or not. Ray, how do you feel about that? Huh? How do you feel? Hey, if you feel good, I feel good. So let me say this before Ray comes and closes out, that I want to thank each and every one of you again. Give yourself a round of applause.
First of all, before I do what my boss says, someone left their phone outside. Metro PC. Oh. It says, be ye ready at all times. Right. I don't usually do songs. I usually sing at mostly funerals. Because my background is that, some of the songs I sing, people usually, churches usually call me and ask me to do that. I don't sing with the group. I'm a freelance. So I'm just going to pick something that I think will fit everyone in this room, especially men. And the song says, I'm just a living testimony. I'm a living testimony. I could have been dead and gone, but Lord, you let me live on. I'm a living testimony, and I thank the Lord I'm still alive. Oh, I'm a living testimony. You know I could have been dead and gone. Oh, but Lord, you let me live on. I'm a living testimony, and I thank the Lord I'm still alive. I've seen miracles after miracles form in my life. You kept having mercy on me. I don't deserve to be alive. When I faced dangers I couldn't see, Lord, you kept your angels encamped around me. And I just want to say thank you, Lord, for keeping me alive. Oh, I am, if you want to join me, I'm a living testimony.
living testimony. And I thank the Lord I'm still alive.